So we're going to start with everybody introducing themselves. If you can just tell us your name, your affiliation, and your background, and we will start with Christine.
Good afternoon, everybody. Thank you so much for the invite. It's such a pleasure to be here. So my name is Dr. Christine Ekechi. I'm a consultant obstetrician and gynaecologist in London, part of Imperial. And I also work with the RCOG on our fibroid position, which hopefully you all would have seen. And I'm also executive producer of a short body horror film called Mango in relation to fibroids.
Hello. My name's Yvonne. I'm one of the trustees of Fibroid Forum UK. I am a fibroid sufferer, and in my career, I'm IT professional in projects.
Hello again. My name is Helen Dozy. I'm one of the trustees of Fibroid Forum. I am a sufferer, and I think I will be referring myself back to a hospital as soon as gain, because I'm still going through issues. In the past, I worked in the City of London, the financial sector, but now I'm kind of doing a lot of different projects within my local community, which has actually been kind of amazing and interesting.
Good evening. Good evening already. Sorry, I do apologise. I've had gruesome elections. So, good afternoon. My name is Elizabeth Ige. I'm one of the councillors for Woolwich Common in the Royal Borough of Greenwich. Firstly, I want to thank Dr. Priscilla and her team for inviting me. It's such an important topic. I've also worked in financial services for 15 years. As a counsellor, I deal with women on a regular basis pertaining to fibroids and obviously periods and how they navigate white-dominated spaces in the corporate world, or just in general, the systemic barriers that they go through, especially being a woman of colour, pertaining to the healthcare system and how they're overlooked and not listened to. So I am a really, really big advocate of it. I've not suffered from fibroids myself. However, I have suffered from really bad, excruciating periods, and that has impacted my life a lot from a political stance and also from a workplace as well. So this, for me, I'm just really excited to be a part of this conversation and be able to contribute effectively as well.
Hi everyone, my name is Sonna Payton. I'm the founder and director of an organisation called Black Mothers Matter. We exist to support and celebrate Black pregnancies and address some of the disparities we see in experiences and outcomes for women racialised as Black compared to others in the perinatal period. As our reach has grown, our conversations have kind of widened further than just the perinatal period and covered much more kind of womb health, women's health, and health literacy, and addressing health inequalities more generally.
Hello everyone, my name is Leila Agbedion. I am a registered nurse from the Netherlands. I'm the founder of Fibroid Foundation Netherlands and of the health platform Womb and Grace. I'm a fibroids advocate. I have had 17 fibroids. They were removed successfully not too long ago. Had a whole infertility journey with that, but right now we have a beautiful 10-month-old daughter.
All right, thank you everybody for such a powerful introduction. And thank you to Yvonne and also to Ellen to also introducing the session, which is the Patients Awareness and Empowerment. So just building on from that, I would just like to open the panel with this question. So Yvonne and Helen did mention some of the current gaps that we have when it comes to addressing fibroids. So from your perspective, what do you think is the biggest gap between women's lived experiences of fibroids and how the UK healthcare systems respond to it? For context for Leila, it would be how would the Dutch system respond to it? So anybody who would like to start on that? Yes, so what is the biggest gap between women lived experiences of fibroids and how the healthcare systems responds to it? For instance, in the Dutch system, how do they respond to it?
Well, thank you for your question. I think as one of us already mentioned it before we started the panel, is that it starts with your GP. And that what I see in the Netherlands is that that's where it starts from. A lot of women often tell me that they don't feel taken serious by their GP, and a lot of women just hang there and they don't take a step further, like maybe looking for another GP or another professional to get answers from. So I think it really starts there, and I think it's a worldwide problem, not only necessary in the Netherlands, it's a worldwide problem because you hear this issue everywhere, and I do feel and think that we as women need to stand up more for ourselves. So if you feel unheard and unsafe and you feel like your GP is not listening to you, that means you need to look further and don't just stand still, because when you stand still, that's when the issues only become worse and grow even more.
I think I'd probably add, I think there's often a focus within NHS systems on clinical solutions, whereas I think the issue of fibroids would benefit from a more holistic approach and response, as people have said, and I'm sure kind of people with lived experience will testify, like it impacts so many elements of life, and sometimes the clinical intervention is not all that's needed, but it sometimes feels like the support or responsibility of the NHS does stop there. So I think a more holistic, I know we always say it, but person-centered approach would really help.
I think just to extend from the other two panelists, I would say I believe the biggest gap is that women are not being listened to early enough. I think women often normalise severe pain, heavy bleeding, exhaustion, fertility concerns and emotional distress because society has conditioned them to believe these symptoms are simply a part of being a woman. I think especially for women of colour, there is a cultural stigma. I think we have delayed diagnosis, and I also believe that these experiences where symptoms are minimised and dismissed, by the time many women receive proper support, their conditions may already have significantly affected their health, confidence, work, relationships, or mental well-being. We also cannot ignore the wider healthcare inequalities that disproportionately impact Black women, especially. We know that there is long-standing concerns around delayed diagnosis, maternal health disparities, pain being minimised, and barriers to culturally competent care. And we know that Black women in the UK are still significantly more likely to die during pregnancy and childbirth than their white counterparts. And those wider inequalities naturally shape how many women experience the healthcare system overall. So for many women, particularly women of colour, there can be a fear that their concerns were not taken seriously or fully understood. And this is why we trust representation, education, and cultural awareness around the healthcare system. It's really important. I mean, as a mother of two, I can give an example of when I had my second child. She was £10.9. She was quite a big baby. I asked for painkillers during the time that I was in labour, and I was denied profusely. They said, don't worry, you're strong, you can handle it, and I nearly died giving birth to my daughter. So the thing of being overlooked and disregarded, it is really an important topic, and there really does need to be more awareness around that. We need to ally with people, you know, the healthcare system, with researchers, clinical researchers, and also with political activists as well, like myself, just so that we can champion change. There's one thing having the discussion, but there's another thing actually getting fair outcomes.
I completely. I was going to say, I completely agree with everything you've all said, and actually some of them are on my nose. I have to keep going back to my nose because my brain is like at the moment. Yeah, I mean, if I say about the NHS, how it responds, as my cousin would say, lastminute.com, basically. Everything is last minute. They don't take you seriously, they can be quite condescending, and actually, as far as GPs are concerned, I'm sorry if you're a GP, but please change. Listen to us, because now we have become the experts. I'm the expert of my body, not you. So there's complete disconnect. I didn't think I would say this in this current climate with regards to America, but most American women, you talk to them, they know who the gynae is. They know the gynae by name. We need to cultivate that culture from a young age for girls, and again, I say 15, 16, we need to do that, because otherwise there's going to be a problem. I'll give you like talking about saying we can suffer pain, etc. She doesn't kill me. My goddaughter, she's about 19 now, and her mom and I have been friends forever. Her mom had really bad periods growing up. Her auntie had the same, her grandmother had the same. When I went to visit them, she was complaining, she was suffering, she's been on the pill, it wasn't working out for her. And her mom said, oh, that's just the way it is. And this is only about 2 or 3 years ago. Her mom's a medic, her father's a medic, and they're telling her to suffer it. And I was like, no, because of where I am, where I've been, what I know, I was like, no, things have changed. Go to the hospital, go to the doctor. Get yourself referred to someone to go and speak to about your pain, your period thing. You cannot live like this. She did actually do that, and now thankfully she's living her best life, living in Australia. So that's what I want for the people coming behind us, to have a better option, a better life, because otherwise, if you suffer from something like period pains or that part of the body, reproductive pains, it's hell. It really is horrible, and it will determine what you do and what you don't do.
Just to add to what Ellen said, for me one of the biggest gaps is educating young women about periods, what are good, what is a bad period, what is a good period. And I think that needs to be in the education system. They need to be taught. Because when I was diagnosed, it was quite earlier on, and it was just by accident, by a nurse that discovered that, she said, you're a petite woman and your womb is enlarged for somebody that is, petite. And that's how I found out I had fibroids, even though I had bad periods. So in my opinion, in the system, education system, young women need to be taught about their bodies and what's good and what's bad. And I'll end it there.
Thank you all very much for sharing your experiences, and we couldn't agree more. There is a big mismatch between the experiences and the reaction of the healthcare system. Next, we're going to direct an individual question to each speaker. So, Dr. Christine, you work at the front line of women's health. In your experience, what are the key barriers to women with fibroids getting a timely diagnosis?
Thank you. And it's so important, this particular question, because it's about us moving the conversation as to what we know the issue is to where we're actually going to make change. And really, this is about understanding the systemic barriers. Understanding the systemic barriers is not just where we stop. It's about identifying those obstacles and then actively moving them. So this is where we are at the RCOG. We know that if we look at the healthcare system in the UK, as it starts off with, we've mentioned about GPs, and yes, there are terms as GPs being the barriers, but actually GPs have a lot of pressure, and I think it's important for us to understand why it appears as a barrier from the GP's point of view. So for us at the RCOG, and for people like myself that work in policy, it's about saying, how can we then support GPs to be able to then hear women properly? Often when we see that women are not being heard, it's because the people who are there providing the care do not have the time or the system to support them to listen to the women. So this is about, first of all, having enough GPs. It's also about expanding the appointment times. What we found is that as we are rightly talking more about women's health and about fibroid care, women are then going to see their GP, but they're not being able to see the right people or see the right people timely. Now, we're not going to be able to magic 100,000, 200,000 GPs. So how can we think outside the box to implement care right from the beginning in the community. The RCOG statement starts to look at that. It starts to look at a healthcare for the future that can start to speak to women and hear women from the community. But that's not enough. Because when women are diagnosed with fibroids, are they going to be able to see gynecologists such as myself wherever they are across the country and get the best and standardized care? The second barrier we know is that there is a postcode lottery when it comes to the right care for fibroids. So the next step at the RCOG is for us to work towards a standardized diagnostic and treatment pathway so that whether you are in London or you're in Liverpool, you will get access to the best care. But all of this must be done with the women being at the centre. There's no point us designing new systems when we're not speaking to women to understand what they need and also to check us sometimes as well when we think we're doing the right thing, but sometimes we are not. The next thing is that we also have to look outside of the confines of the British Isles because there's so much that's being done. We look to America, but actually there's also lots of great work in sub-Saharan Africa. If we look at the burden of fibroids, we know actually that's going to be greatest in countries such as Nigeria and Ghana. And sometimes we have this oversight where we think that the best and novel innovations are happening in the West. And I think actually sometimes we need to reach out to our partners in India, in sub-Saharan Africa, and say, actually, what are you doing? What are you doing to try and manage these very big fibroids and minimize the bleeding, the morbidity and mortality that comes with the operations? And then finally, there has been this mention of holistic care. This is front and center. One of the things that's been so tragic to see is that women have been spoken about as if they only comprise of a uterus. It's not just about their uterus, it is about their lives, it's about their fertility, it's about them, progressing in their careers, it's about them having choices. And so as we're building these systems, are we building them together with our fertility colleagues, with our nutritional colleagues, because we have this huge gap of really understanding the role that nutrition plays in in fibroids. And so that when we are then creating and designing pathways for the future, we do so and make a system that is robust not just for now, but for many, many years to come.
Thank you so much, Christine. That was really comprehensive, and we look forward to discussing this further during the event.
All right, thank you. So for Helen, I would like us to just touch on empowerment for a bit. And from your speech so far, I have identified that you do quite a very good job at empowering women. So I just wanted to ask, how do you go about empowering women with fibroids to make informed decisions about their fibroids?
I think essentially providing that safe space like we do in our support group, building their confidence, letting them know that they matter, what they're going through matters. We listen to them, educating them and letting them know what treatments are available, etc. And also for them to also making them feel stronger, advocate for themselves, research, just empower them to go and also do research, because when they go to their doctors, clinicians, etc., then they know what to expect, and they can I think if you're educated, etc., then you're empowered. If you have that knowledge, you're empowered, and that really matters, because no one's going to know your body more than you know your body, but you have to be able to vocalize how you're feeling, etc. I always say to people before you go for your appointments, for example, make notes about how you're feeling, what issues you're going through, if it's psychological, emotional, because when you get into that room and you have that 10 to 15 minutes, you can forget everything. I know what I'm like, so I really do say, your phone is there, use it for that, jot down the notes on a piece of paper, and also obviously by the time sometimes we're going through the fibroid experience, you have partners, get the men in your life involved as well. They are part of you, so whatever happens, for example, when it comes to fertility, men matter. And we've had some men, thankfully, come to the support group as well. And for some of the symptoms that you're going through, they will say it. They're not like, detached from it. So we do need them to partner with us to fight this fight, and get through the whole thing. And definitely, I'm trying to think, just empower them to like speak up for themselves, etc. So I think that's really, really important, and get like really good relationship with people that can advocate for you as well.
All right, thank you for that. I believe it is very important to empower women on this decision, especially when it comes to knowing your period overall as well, because as a young person myself, I found that that's something that we do struggle with a lot, with identifying what is pain and what is my score of pain that I should be looking at. So it's very crucial for that as well.
And the other thing I would say is also, for example, like as Yvonne, you touched on it, what is acceptable period? If I go to the doctors and I said, if they said, I'm using like a tampon and super maxi pads, etc., that should tell you something's not right. And in my case, actually, no one ever asked me as to what my periods were like. But I've had an endoscopy, I had a colonoscopy, because they were trying to find out why I was so anemic. So that could have saved not just me. That whole process is not comfortable anyway, but they're horrible. And also the time and resources from the NHS, which is already like suffering. It's a waste of time. But I also didn't think about it, because for me by that point, my periods were just normal, even though they were heavy. And we can like cross that out immediately, and the cost of it. So,
All right, thank you. Pass on to Dafina.
So, Yvonne, building on what Christine said earlier about putting patients in the center of the new systems we're building, in your work in Fibroid Forum, how do you find out what women's most urgent needs are?
Okay, what we found out is I named 3 the most common thing: painful periods, blood loss, and fertility. And I know concerning fertility, there's some debate whether fibroids affect fertility or not, but that seems to be a big issue. When women attend our support groups, they get conflicting information. It's inconsistent, basically, and it's one of the biggest things. And dealing with very painful periods and blood loss is major as well, because I can identify with that, because that was one of my problems. It wasn't so much being pain, but blood loss was a massive issue. So those are the 3 things that I can point out, and especially fertility as well, because especially women that are trying to start a family, they're told various things: you can't get pregnant, and you name it. But it's a major thing that we find in our support groups.
Thank you, Yvonne. We couldn't agree more. And to continue, I guess, with the theme of fertility, we have a question for Sona.
Yes, building on that, just to emphasize, we are running out a bit of time, so we would like to quickly go through the questions. So just for Sona, actually, so I am quite curious as well. So from your experience as a maternal health advocate, what have you seen so far to be what impacts patients with fibroids and pregnancy? So what have you seen fibroids impact the lives of pregnant women so far?
There have already been so many good points raised, so I'll try not to repeat those. I think one of the biggest things is if someone as part of their preconception journey has had to navigate fibroids, and they have likely experienced medical gaslighting, kind of dismissal, misinformation, no information, perhaps fighting to keep their uterus, and that is part of their preconception journey. When they're during pregnancy, these women are exhausted. I guess it's very hard for them to be vulnerable and lean into maternity care and maternity systems, because unlike professionals, people or NHS users don't always distinguish as clearly as we do between different disciplines and different types of care and different types of medicine. So a woman trying to conceive from the start of kind of managing fibroids up until, you know, the postnatal period is all part of one system, and if the start of that is hard work or problematic, it makes the rest of the journey increasingly difficult too.
So I'm actually curious on that subject. So have you actually encountered women contemporarily whilst they're pregnant to also have fibroids, and they have to combat that together at the same time?
Yeah. So, or women who have fibroids and are currently pregnant, and for those women, often it feels like just instantly a lot of choice is removed, and one of the kind of hardest things to, or most harmful things in pregnancy and when giving birth is when you feel like it is not within your control, and fibroids definitely contributes to feelings of that.
All right, thank you. So talking about impact of life, right, okay, Dr. Christine.
So I just wanted to come quickly back on the back of that. Everything that Sona said is incredibly true. And this is where, when we're talking about gaps and we're talking about legislative change, it's about also understanding our knowledge gap so that us as clinicians can adequately and more definitively inform women. Now, fibroids does not equal infertility, but some fibroids may. And it's about being able to diagnose early those fibroids that may impact on fertility, be able to then educate women so that they can have the right choices to then deal with those fibroids that doesn't result in always a surgical input that may then impact on their pregnancy journey. And where women are diagnosed with fibroids in pregnancy, where we know it can impact the pregnancy journey and their post-delivery journey, that again, as clinicians, we are really adequately informed to be able to support those women. So I think it's important about that knowledge that we give at the beginning. We don't want to scare, but we want to inform.
Thank you so much for this input. So next question is for Leila with the Netherlands aspect. We are interested, has your own career as a nurse shaped your activism around fibroids?
Oh yeah, absolutely. As a nurse, I am the nurse that is very feisty. People know me as very feisty, as the one that always speaks up, the one that always argues for people. But then I found myself in a situation whereby I was diagnosed with fibroids because I wanted to have children. And then all of a sudden it was like, do you have fibroids in and around your uterus? I had no clue what that was. I've never heard about it. I was like, fibroids, what are fibroids? And then my mom told me that she also had a fibroid. Never knew. So that was very interesting. And I grew up in a Nigerian home, very strict home. I was taught to be silent. I was silenced. I had to get good grades, make sure I look good, make sure I don't put the family to shame, but do not dare speak and use your voice on a platform. So when I got the diagnosis, and I'm a Christian, I prayed to God and I said, if you give me the fruit of the womb, I will use my voice to help as many women as possible. So when, after my myomectomy, after 8 months when I got pregnant, that was the biggest shock of our lives because I thought that I would never conceive again. I made it my life's mission as a nurse to change as many lives as possible with my testimony. So that's where it started. So my career definitely took a 360 turn just because of speaking openly about fibroids. And it shocked me that in the Netherlands, there are so many women that go through this thing and they're just quiet and silent and they don't speak about it because taboo culture, the womb in general. Like, why do you even talk about the womb? You should not speak about the womb. I was judged so much when I put my first video online talking about fibroids and my journey. I was told, why would you put that there? Men will think that you're infertile. These were the words that were used. So the more I get those negative response, the more I am going to use my voice. So as I said before, it became my life's mission as a nurse. And I've always knew that I'm more than just the nurse that will be just at the bed and helping people. I just knew that I needed to do more. So I hope this motivates more people in the medical field, but people in general, to absolutely use their voice. And this one thing that Samira taught me these past weeks is that you're the lawyer of your body. So we really need to learn how to stand up for ourselves and speak up. And if you can't, there's always that friend like me that will speak for you, because best believe I will bust open those doors in the hospital and be like, you're gonna listen to me today. And I hope we all will learn that today and take that with us when we leave this place.
Thank you thank you for being in our corner, seriously. And your reach is just incredible.
All right, thank you for that. As Leila has said, actually, our voices are very important when it comes to this context. So I just want to ask Elizabeth, from the perspective of a transformation specialist and also a leader, how have you gone about how do you go about advocating and empowering women within your constituency and also nationally when it comes to fibroids and menstrual conditions?
Yes, I think that's a really good question. One of the reasons I became a counsellor was because I wanted my voice to be heard. Like many women, we navigate male-dominated spaces and we are silenced, especially those from particular cultural backgrounds. I think one way to create awareness is to lobby. So I'll be lobbying with my colleagues, with MPs. I think it's also using scrutiny forums as well. We have a health scrutiny forum. I think it will really be good to create some sort of awareness with this. I also think it will be good to partner collaboratively with schools and faith groups. I think that educational piece is really missing. We've all spoke about young women, and I have a daughter who's 13. She also goes through heavy periods like myself. I took her to the doctor, the same way I've gone to the doctors and I've had scans. Like I said, I don't have fibroids, but it's really difficult navigating my periods on a twice monthly basis. I do feel that awareness piece is really, really important. Just educating people from primary socialization, because a lot of young women do not know what's going on with their body. And I feel linking with policy changes as well is really important, just so that people are protected in the workplace. You do get unfairly discriminated sometimes when you do go through such things. There is a taboo around it. I have been in circumstances, when I've been working and I wasn't able to go to work. However, I would still work from a working from home capacity, and having to have those difficult conversations with male counterparts on a senior level, because I only had males that I reported into. It was really difficult to be open and honest and transparent about exactly what I was going through. So I think that educational piece as well in a corporate space is really, really important as well, just so that we can provide support, because support is needed. And I think the more we talk about it and the more we do events like this and the more we kind of work together collaboratively and strategically, I feel that we'll be able to create a better outcome for everybody.
Indeed, it is very important for us to work together collectively as well.
This way, we'd like to also include everybody in the audience, also in our live stream. Please ask your questions for our panel. As far as I understand, we have already a question from our live stream, so if we can hear it now. If you can come up and on the lectern mic and say the question.
Thank you. Can you hear me? All right. Okay, I'll try. So there is a question from the audience, relevant to what we have been talking so far. So how do you become an advocate for fibroids, and how do you take part in research on fibroids? So what is your experience on that? How do you
I'd like to take this one.
We heard some of you already, but...
Really? I don't know about gosh, I guess there's no real way. Just be, there's nothing, be human, be kind, be helpful, and be supportive. I think that's probably the best way to be an advocate, because we don't have any like formal training or anything, but we know what we've been through. And so we're always there to be supportive from the beginning when some women come, when they're starting the journey, or towards the end when they're about to have the operation, because I think that fear and worry is there, which everyone suffers from anyway. And as for research, I am like on that internet, like no one's business, and I'm not joking. Even prior to like, I mean, there's so much more information now. I probably had my operation about 15 years ago at Imperial College, St. Mary's, which was linked to Imperial. And they had like, they were in the whole country, the only place that said they had a fibroid clinic, and they were like quite holistic about it. They had like a urology next door, they had the fibroid clinic. So that's what you want, people who are thinking about the whole issues surrounding fibroids, because there's so many different things. Like, for example, now it seems like this, what is it, hypertension can be caused by fibroids as well. So I've got like high blood pressure, but why? I'm active, I'm everywhere, I'm running. So there is so much more information now than ever. And I think the internet, I'm not to say that everything on the internet is right, but then I go to doctors and they'll Google as well. So if they can Google, so can I. Yeah, and there's no one place. And as it is, I feel like we're getting more information now, things are changing, there's more interest, more research happening, and more sharing of information. So it is out there, we just need to like find it, but use it sensibly. What is said on the internet is not right for everyone, but you can like look at it and be critical of information that you look at. Yeah.
Just to add to what Ellen said, I think it's important to speak to clinicians, researchers, gynecologists to get the correct information. As Ellen said, you can go on Google, it's not always correct. Social media is not always correct. But I would suggest to anyone that's interested in promoting or getting interested in being an advocate is to contact professionals and get the right information, because there is what we found in our support group and what I've found on social media, being our support group, is on social media, we've got a Facebook, there's so much misinformation out there. People can be disingenuous and prey on women's emotions because they're so desperate to have a child, so desperate to get healed, get rid of the fibroids, the bleeding, and you have people out there that are not genuine. So in my opinion, I would suggest go to the professionals, get different opinions, and make your own judgment. If you're not happy, go to the second, the third, the fourth person if needs be, but someone that knows exactly what they're talking about.
Thank you so much for this. Do we have, yes, in the back. Oh, with that one, okay. There.
Thank you for such an exciting, insightful, and detailed and truthful account of what fibroid life is. My name is Josiane. I'm a scientist and etc., etc. My question is for Dr. Ikechi and perhaps anyone in the panel. From a science point of view, I'm amazed that we are on the 6th or 7th iteration of Viagra. Just facts. And I don't see, or maybe I haven't looked far enough, I don't see a research program into fibroids. And you talk about the holistic approach. You cannot look at the human body, let alone women's body, and exclude the connections between the nervous system, the reproductive organs, the microbiota, etc., etc. The technologies are there. I happen to know them, I've used them, I sell them, I promote them. Why is there such a disconnect between what can be done and the appetite to do something from a research point of view?
Thank you so much for that question. It's a really pertinent and valid question to ask. The truth is, there is a knowledge gap when it comes to fibroids, and what I mean by that is not just the clinical impact, but it's the biological processes that indicate why some women have fibroids over than others, and more importantly, why some women not only develop fibroids, but develop very big fibroids. There are some women that have fibroids and they remain small throughout their lives. So really the question is, why do some women have fibroids and those fibroids grow significantly in their reproductive years, then causing the huge impacts to their lives? We have a huge knowledge gap there. The question as to why we have that knowledge gap is not because the information is necessarily so difficult to determine, it's because the focus hasn't been there. Now, we can talk about the structural inequalities in research and academia. That means that who is it that determines the questions that require investigating? Ultimately, what drives research and the funding of research is that people will want to research conditions that they identify with. This is where equality matters. If you don't have the people in the room where these decisions are being made as to the research questions and the acquisition of funding, to perform research, it is incredibly expensive. It's hundreds of thousands to millions of pounds. You need to have a research team. Where you don't have the black women in the rooms to even mention that there is this condition, then it remains an invisible condition. So at the RTOG, when we were forming our position statement, we understood that we could not talk about a new system without building in the frameworks for research. That is about supporting new researchers, young researchers who have those great ideas, but because of structural inequalities, do not rise to the top of the academic chain. We have to recognize all of that. Unfortunately, the effect is where we are now. So when women come to my clinic and they ask me about red meat and fibroids, I can't answer them with the robustness that I need to, whereas if I were talking about endometriosis. And I will just say quickly here, obviously when I was at medical school, I was taught that endometriosis was a white woman's disease and fibroids is a black woman's disease. And we know now this to be false. I mean, the most difficult hysterectomy I ever performed for fibroids was actually on an Irish woman. But we do know that fibroids, morbid fibroids, tend to appear more in black women. But the iceberg that is only just appearing is that black women actually have a much higher prevalence of endometriosis than we ever considered. And there's a huge overlap between endometriosis and fibroids. Now, some of us do realize this. So I think it's about having conversations like this, but in institutions such as this that have such an academic record when it comes to resource, so that we are collaborating, we are saying, well, look, we need to think about these questions, and how can we also bring in technology? How can we bring in the new advancements that have advanced men's health, as you've described, but also continues to advance women's health?
Christine, we are truly excited to be participating in the future research in fibroids, honestly. Truly. Okay, next question.
I think we're running out of time, so perhaps.
Thank you very much. I'll be very quick. My name is Tumi Hawkins. I live here in Cambridge. I've just recently been a retired counsellor. I think I know you, Elizabeth. Retired counsellor of 16 years. I'm also an activist in my own way. Thank you very much to Dr. Priscilla and her team for putting this together. I haven't had it personally, but I have had people in my family who have suffered fibroids. My sister, my younger sister, 10 years younger than me, she's infertile because of it. My mother had it. She had her operation to remove her hysterectomy when she was 80, but she had 4 children. I had a friend who also was told to have a hysterectomy so she didn't have to have it. Now, there's all these experiences, but my question really is, do you think there should be a research into whether there is a genetic link to fibroids? Because not only did my mom have it, my sister had it, And I think my aunt, who was my mom's sister, also had it. So maybe there is something there. I don't know. It's just a thought. But thank you, everyone. It's been good to have all these ladies talking to us about this.
Thank you so much. So we do know that there is a genetic predisposition to fibroids, but often that's not the full story. Somebody can have a genetic predisposition, but often then it's an exposure to other factors, and those other factors will then potentially determine the rate of growth. So I think this is where the research gap needs to be filled. As I said, some people have fibroids, but the fibroids don't necessarily grow to the same rate. Now, whether these are environmental factors or other genetic linkages that we haven't quite found, I think this is where the novel and exciting research frontiers are.
100%. And I think with this question, we're going to draw our session to a close. Thank you all very much. If you'd like to speak further to all of our panelists, please join us in the upcoming break. So, from what we've discussed now, one thing is clear. I think that awareness of fibroids is not enough, and true empowerment comes from the full participation of all layers of society, the healthcare system and policy, and we are working together to make this happen. So thank you all very much.
All right. Please join me once again in thanking all of our panelists, Dr. Christine, Yvonne, Helen, Elizabeth, Sona, and also Leila for joining us today for powerful insights as well again. Perfect. So we will now quickly have a brief 20-minute break, but before that, I would like you to also join tomorrow. There's another talk happening here in Cambridge at Homerton College again, and it's the Katy Perry lecture, which will be based on women in sports. So if you are very active like me, please make sure you join the talks. And this will be a guest speaker, Baroness Tani Gray Thompson, who will also be joining. And it starts at 5:30 tomorrow, I believe. So we'll just quickly head towards the corridor that way. There are signages, which will show us where there is a break room, and that will be 20 minutes, and we'll be back here at 2:25, 2:20 preferably. Thank you. Thank you so much.
Afternoon, everybody. Can you hear me, first of all? Yeah, lovely. And such a pleasure to be invited. Thank you for having me. I am a GP. I'm hoping not to get booed and hissed. I'm one of the good guys. I'm trying to make some change, okay? I come in peace. So I'm going to share with you the model of care that we established in Birmingham. A women's health hub is what they call it now. I'm going to tell you a little bit of background and story as to why it was innovative or is innovative, very inadvertent innovation. And then I'm going to talk you through what the model looks like and a little bit about fibroid care. And I hope to stick to time. And that is not my slides, so I'm going the wrong way, am I? Yeah, okay, there we go. Aha, brilliant. Okay, so first and foremost, we are a large GP partnership, one of the largest in England. So modality partnership is about 500,000 patient population with actually about 12 million citizen reach in total. And that's a general practice side. So we're your bread and butter GPs, but we're just a lot of us across England. And we also have an outpatient services, which has been established for about 10 years, of which there are 18 outpatient services. And we serve approximately 150,000 appointments for the NHS on an annual basis. Some of that is in women's health. So we're just big. We have been working quite tirelessly with sort of our acute trust, not just in Birmingham, but in various other areas, to actually reduce the backlogs and to drive down waiting times. So that gives you a bit of an idea of where we're at now, but I'm going to take you back to how it all started, okay? And I've been told off a little bit by using language that's not PC, so I'm really sorry about this, but I'm going to try and say things that are diplomatic and tell you that I was a GP in Aston in Handsworth. Has anyone been to Aston in Handsworth? Yeah, you'll know what I'm talking about. It's a slightly deprived area, okay, with lots of diverse populations. And that's my bread and butter practice. Before I even knew what health inequalities meant, that was what I was dealing with on a daily basis. And approximately 10 years ago, as part of David Cameron's sort of government initiative, there was a pilot called Vanguard. And the slogan of that was to bring care out into the community, similarly to what we're trying to do now with neighbourhood teams, of course. It started off with a pilot for 1 year, and women's health was not a focus. I'll emphasise that. Women's health was just nowhere, because actually the waiting times weren't that bad. People were seeing within 6 months, and it wasn't so much of an issue. But I had a golden opportunity, a blank sheet. And I sat down with a managing director who had a wealth of service mobilization, so she could design services. And I had a finance director who could map out everything that I was doing, costing it out, tracking it, put the business case together. And we planned this service, so I was just basically said, what do you want to do? So bearing in mind I'd been a GP in that area for a while, I was kind of thinking, why are women going to hospital? Because they're waiting for this appointment, and it was only 6 months then, not a year or year and a half as it is now. And they would wait, and then they wouldn't understand what was going on, and they would come back, and then we'd have to talk through the condition and then the possible treatments. Now, that wasn't because of the consultant who was seeing them. This is not me now having a go at consultants, don't worry. But it was more because everybody was under pressure, even back then. So consultants are still and were then asked to see and treat and do the needful, okay? So people under a lot of pressure not to continue to follow up people and discharge. And a lot of women, due to lack of awareness, maybe language, maybe literacy, weren't really getting it in that single appointment, okay? So it's a very pressurized environment. So this is where the inadvertent innovation started, okay? I asked myself, when I wrote 2 questions down, I didn't actually, but in my head, go, why would a woman need to go to hospital in the first instance? At what point do you need to cross that threshold into a hospital? And in my book, I define that as you needed a general anaesthetic or complex care. So absolutely everything else we can pull out, okay? All the procedures we can do under local anaesthetic, for example, hysteroscopy, which I do out in the community, could be done. So we pulled it all out. So the only exclusion to the service and to date is cancer care and fertility. So we do fibroids, we do endometriosis, I'll give you a list, we do it all. The second question I asked is, why do you need to see a consultant gynecologist? And the reason I asked that is that these are highly skilled people, okay? They're at their very top game, highly specialized, spending many years getting to that level. They are also our most expensive part of the whole thing if you're putting a business report together. So why would you get them to see the first kind of like, first appointments or the simpler stuff? Why don't you tier the complexity so that they see more complex stuff or more specialist stuff? So that's how we started, and we worked backwards. And there's the list of stuff that we see. So we are a primary care-led, and still are to date, consultant-supervised service. So we are a hybrid group of GPs, nurses, pharmacists, consultants, and we all work together with integrated pathways. When I say integrated, truly integrated, that means that we've all discussed what those pathways look like, we've agreed them. When there's a handover, there's no repetition, so you're not going to have another scan or another biopsy or another hysteroscope. And actually, if you are needing surgery for fibroids, for example, you are consented out in the community, and then you are listed. And the next time that you then go for your operation is your pre-op or your op, okay? And that's what I mean by integration and a seamless pathway. I am definitely pressing the wrong button. Sorry about this. I will get the hang of it. Okay, so GP-led, we triage quite quickly. We are primary care triage, so that means that we receive referrals directly from GPs, and the triage is done via GPs and nurses. And we also receive backlogs or waiting lists from hospitals that are struggling in and around Birmingham in particular. We have diagnostics that you need to be able to know what your condition is, okay? And we pull that all out into the community. So ultrasounds are basic, but hysteroscopy was the big thing. For bleeding, for fibroids, that's the gold standard, that's what you need. We have a less than 1 month wait list for hysteroscopy, okay? And we always have for the last 10 years because we're able to stay on top of our needs and our demands. And we now started to move to one-stop. So we can't do fibroids out in the community because they bleed too much and you might need to stay in and it's not safe to do. But actually we will do the small polyps and we'll do ablations and things like that. So we have pushed as much as we can out into the community within the realms of safety. As I said, we are consultant supported, so I've got one of our consultants here. And we've got quite a few consultants over the years who've been brilliant. We've got endometriosis, urogynae, who have got all of their own expertise that they bring out into the community and then take over the care if needs be. I'm not going to get too technical in what we do, but obviously we need to do procedures. It's not all about the procedures, but this just goes to show that this is what the kind of stuff that is needed to be delivered to be able to understand what care you need. But this is the key thing that I want to show, and I want to just hover on this for a little bit because this is 10 years of hard work and things that we would like to emulate and see up and down the country. And I was really happy to meet the team from Cambridge on calls who were trying to sort of, learn and hopefully, fingers crossed, one day will be doing their own thing too. So we triage quickly. That means that when we receive a referral, we will either advise and guidance back to the GPs, or we'll reject and say that this needs to be in hospital. But actually, 99% of the time, we will say, yes, we can see them. We see people quickly, within 37 days of the referral being received to us. That's not having sat on a waiting list elsewhere, that's to us. But this is the key thing, the one down at the bottom. When I first set up the service 10 years ago, it's okay. I was worried I didn't put my phone on silent as well. So when I set up the service 10 years ago, it was almost a proof of concept. How much could you pull out into the community? How much is safe to do? What's the culture? What are the barriers? Will people support us? Will they kind of go, no, you've got to give this care back to the hospital? Would there be a kind of clash between primary care and secondary care? But that 7% means that, yes, it can be done with the right level of skill set. And obviously, I've had a lot of training, which I probably should have mentioned at the start. Prior to even starting the service, I was upskilled as a GP to do various bits and pieces. But it meant that, yes, you can do it. Less than 10% consistently over 10 years means that most women and their conditions can be dealt with in the community by a hybrid team. That 7% is the surgical patients, is the complex stuff that we can't deal with, like the children, like the fertility, like the uterine embolizations that can't be done out in the community, for example. I think the other thing that we're very proud of is the fact that our patients like what we do. Okay, we're not perfect, but we have consistently sat much higher than any of the other NHS outpatient services. I think there was a report via the King's Fund that we benchmarked against, and 80% of our patients would say that they would be happy for their family to be seen, happy within the service. Bearing in mind that some of these women, because it's anonymous, it's a text that's just sent to absolutely everybody, we don't screen, have been sitting on a waiting list elsewhere for a year and 18 months, and then we've taken them on board in service. So we're pleased about that. The gaps that we have on that satisfaction is the holistic care. And I can talk about that maybe later on in the panel, but we've had some focus groups with our patients to say, you're great in diagnostics and treatment, but actually I need help with my mental health, with my weight, with my diet. We're not commissioned in that way, okay? We do a lot outside of work, in education, in trying to work with various different providers and innovators to be a bit more broader, but we're not commissioned in that way. So it's just a little bit of a nod to sort of say it can be tricky. Just to bring the focus just back onto the topic of the day, what do we do around fibroids? Well, I think, the key thing to say is we have the diagnostics, and that is really important. We talk about women needing to be heard, but they also need to be managed and to actually have the diagnostics quickly. So we know what type of fibroid they have, where it is, how big it is, etc. So we have not just scans, but we have hysteroscopy, and we have an MRI machine in the back of our car park, all right, which is hilarious, but I think there's a lot of mobile MRIs, and we can get an MRI done quite quickly. So that's all done out in the community. The images can then be transferred across to the hospital if that's required. We're fully versed, both as GPs and nurses, to be able to initiate medical treatment. So it's not just down to our consultants to be able to, the pressure's on to treat fibroids. We're treating fibroids just the same as our colleagues in all forms. And we know that has started to increase in terms of the options for women, which is great for some. I've already mentioned that we have an integrated surgical pathway. So as soon as they do need to be listed, they are dealt with in terms of our surgical team will consent them and then be listed at the hospital. We do have a lifestyle support app and health coaches. We don't use it a lot. I don't know why. I'm not sure. I think we should push it more, but it is available. It's online, and some women do use it. It's called Goki. So it does provide a bit of mental health, nutrition support. It's something that we probably need to drive forward for most women, in actual fact. It's one thing that I was reflecting as I was pulling these slides together. Last slide from me really is just a nod to Christine and Royal College report that came out, what was it, last week, Christine, is that right? Okay. And I just had a look at that and sort of said, how are we delivering against that report? The call for action was very clear in that report in terms of what we need to do as stakeholders and what we should aspire to do. And I was pleased to say that we are delivering this already, okay? And it would be lovely to be able to dive into that a bit deeper, maybe with some further audits, etc. But it's in place, is basically what I would say. So the reason I'm putting this slide up is not to show off and kind of go, oh yeah, we've been there, we've done that. No, it's to actually say it's doable. Okay, if I'm just a brummy GP who just inadvertently did something that has now turned out to be of help, then I'm sure there's lots of other GPs down the country that can do exactly the same thing, right? So I'll just end there by quoting that report, which is that fibroids should not be the quiet catastrophe of women's health. That was in that report. And look forward to any questions later on. Thanks for your time.
Thank you, Amina, for sharing your experience, and we'll have some questions for you later. Now I would like to welcome to the stage to Obi Naha and Matthew Napleton. They are co-founders of Ascension Z. Their work involves using AI to mitigate bias in women's healthcare. Today's session
explores AI's role in identifying racial bias within fibroid diagnosis. So if Obi and Matthew can come in. Thank you very much.
Other way. Hi, thank you, Francesca, Priscilla, for giving us an opportunity here to talk about what we're doing. We're a Cambridge tech startup, and we've developed this AI platform to really help to tackle some of the challenges here that we're talking about today. And whilst we've been working on this kind of AI platform, which my co-founder will show you a demo, we've also got an exhibition stand at the back, which will give you a live demo of how we're using AI to help in a meaningful way. And essentially what we've been doing the past few years is developing this AI platform is to provide equity in the workforce and in the workplace. And it was a chance meeting with Priscilla, I think about 9 months ago, where she told me what she's doing. I told her what I was doing. And I admit, I didn't know what uterine fibroid was. All right. So then I started to research and look into it. And I thought, look, here's a way of using AI technology in a meaningful way in terms of what we're doing. So then we developed this, and we're going to take you through this demo. But essentially, the AI platform which we've been developing can help. And we've got a specific case here on uterine fibroids. But if you look at our technology roadmap in detecting bias, we can not only detect bias in terms of race, but also our roadmap is looking at gender, neurodiversity, age, and ability as well. So what I'm going to do is I'm going to hand you over to my co-founder here, who will take you through a video of a live demo. And then, as mentioned, in the coffee place, we've actually got a live demo as well. Matt, over to you.
Thanks, Obi. Oh, wrong one. Done the same thing. Okay, thanks everyone for being here today, and thanks for having us. Matthew Napleton, co-founder of Ascension Z. It's been amazing today. I've learned so much in the last few hours about what we're talking about, and I can safely say this is the first time I'm going to do a presentation about AI to a room full of ladies rather than men in suits. So this is going to be fantastic. We're going to give you a video demonstration just because of the gremlins that existed, the Wi-Fi, etc. But as Obi rightly mentions, feel free to come and ask the questions of us in the system in the back in the refreshments room. So we're going to show you a video. We're using AI-created synthetic data. So there's 50 different data points with several different consultations. They're all female, obviously, focused on uterine fibroid treatment. There's a bias detection algorithm in the background, which is working to detect the data. The idea of the platform is it will be connected to a voice-to-text or a voice connection algorithm, so it will listen to consultations and transcribe in real time. We don't have that running right now, but that's something we will do. But it's what we call conversational analytics. It enables you to talk to your data. So what I always say is, if you could talk to your data, what would you ask it? More importantly, what do you think it would say back? That's what we're all about here. Having that conversation, having that understanding and that approach. So we're going to do some summarization of complex transcripts. We're going to see some complex reports. And we're going to see analysis at an individual patient level, but then also across a group of patients as well. So before I kick it off, this is the front end. So put your hand up if you're familiar with Claude or ChatGPT or one of those systems. Okay, great. So this is a large language model, in essence, right? So it enables to have that conversation approach of talking to your data based on the morass of data that it has. It's not connected to the internet. It's a private local model, so your data doesn't go anywhere. You'll see down the bottom that we've got the ability to connect to the internet. We've got web search and a bit about the health equity piece as well. So I'll just set it off. Is it going? Here we go. Should be playing now. Yeah. So that's the prompt we're using. Give me a full report on patient 35 treatment, a table of any bias detected with improvement suggestions, and then a 2-paragraph summary of that consultation. So quite a complex prompt. As I mentioned, we have the ability to go to the web. But on the next piece here, we have what's known as a persona. So this persona is a healthcare equity analyst. So we could have any number of different personas based on individual job roles or individual what people wanted to see, based on that same kind of data point. So you could log in as you and see different ways of responding to the system to look at you and talk to you in a way that you want to be spoken to. So now we're just going to kick that off and give it a quick go, see what happens. Priscilla, welcome. You're there as always. So we're going to kick that off now. And one thing it's important to note is that you don't have to know anything about the data. The system does that for you. We're not asking you to be a data expert or a data analyst or anything along those lines. We're just going to kick that off, and the system will run that analysis for you. Now, it's not a black box. It's telling you why it's done everything. It's going to give you the reasoning behind it. So we can always go back. We can always understand what the system is doing and what it's telling us. So it's going to have a look at the data here. It's going to get the data, pull it back for you. It's going to look at the bias descriptions. Patient 35 is what we're looking here. So we're out of 50. We're just going to have a look at one patient. Patient 35 is quite interesting in this data set, and we'll see why in a minute. One thing you'll notice is that actually it's not called patient 35 in the data set, so it's had to do some analysis itself to pull back the actual information about the data. So again, you don't have to know about the data to ask it the right questions. So now it's executing those queries, it's pulling this data back, and it's going to create some reports as well. So it's telling us everything that it's doing, and it's moving back through the system. One point to note here, you notice this, it's talking about NICE guidance. We can upload documents and other data sets into this backend system. So you can keep uploading it and feeding it with new research, new themes, keep adding to it. So it has more of a morass of data to understand and drive data through. So it's giving us a full report on the patient's treatment here. There's some key findings as well. It's detected some bias, and it's also given us some improvement suggestions on how we can improve the patient's treatment over time. And then it's created us a 2-paragraph summary of that consultation. So we're just going to scroll back up again in a second in this video, just have a look at some of the outcomes that it said. 5 separate passages were flagged for bias. Summary scores of racial 7 out of 10, sex 6 out of 10, disability 4 out of 10. 2-year waiting list for this patient to be seen. That's more of a report, and here's some of the bias it detected. Some of the main bias, why it matters, and then an improvement suggestion. We're not talking about necessarily changing, or making anyone feel bad about what they've done. This is all about improvement, how we improve patient outcomes using data and technology, which is really, really important. We're now going to ask it to actually look at the entire data set now. So we're going to ask for the same analysis, and there's this bias, therefore, seen across the entire 50-person data set. So we're just going to ask that. So we've gone to that micro individual patient analysis piece, now across to the macro of 50. So we can actually look at thousands if we wanted to, but just for the purpose of this demonstration, we've got 50. I think what's interesting here is it actually is going to have an error. It's going to make a mistake, but it will fix itself because that's what the system does. It's able to talk to a back-end data about data technology and actually fix the way it's doing things. So it's actually gone, actually, I'm going to check it. There's the query error. I've gone something wrong, but I'm going to fix myself. I know how I can then answer your question. It's always thinking and talking to itself about how it's going to answer the question. So now we've actually looked at it. It's now run the query, it's completed it now, it's fixed itself, and it's going to create this analysis across the entire 50-patient data set now. I hope. No, it's a video, it's fine. The one thing it can also do for us is create a more formal report. So I'm now just going to ask it to create, it's bad typing. It's now going to create us a report on these findings, or something more formal, something that we can share, something that we can use in a more operational perspective rather than just an instant piece of insight. Something that we can then share, something that we can build, something that we can do, something that we could send out or share with colleagues, something that draws into all the things that we're doing. So we've gone from all the way at the top, from asking quite a complex question around patient outcomes and an individual patient, all the way down through to looking at probably several tens of thousands of individual items to see what's going on. So that's what we do. This is Ascension Z and the platform itself. As I say, there is a live demonstration in the background. If people want to come and ask questions, if people want to see it, people want to see it go in, ask questions. We've got it on an iPad, we've got it on the big TV. Just come and ask the questions and see what we do. But thank you very much.
Thank you for that. And all I just want to add is where we've got to here, because we're talking about what kind of solutions are there for different stakeholders and pathways. We've demonstrated this about 2 weeks ago to senior leaders within the NHS, quite serious people there, about the power and the capability of what we're doing here. So this is just really showing this to you, and then we're looking at collaborations with organizations of actually how we can use that data, how we can detect bias. and then how we can be helping people and how we scale it. So this is where we're in a situation now where we're going to be looking at doing proof of concept and tests and trying it out as well. But thank you. And as mentioned, you can see the demo at the back as well. Cheers. Thank you.
So thank you very much, Obi and Matthew. It was a very insightful presentation on the role of AI in racial bias within fibroid diagnosis. So the next session will be the panel discussion. So my name is Gioia Canciani. I'm a consultant gynecologist at Cambridge University Hospital, and I'm also part of the Fibroids Free team. And together with Professor Hilary Critchley, who is a consultant gynecology and professor of reproductive medicine at the University of Edinburgh, we will be chairing the panel discussion. So may I ask the panel to come on the floor? So if you can sit in the right chair, perfect, and I will sit there. So we have Professor Sue Carr, who has been the Deputy Medical Director at the General Medical Council until March 2026, and is now the Senior Medical Advisor at the GMC. We then have Professor Eddie Morris, who is the Medical Director for NHS East of England from 2022, following his 3-year presidency at the Royal College of Obstetricians and Gynecologists. Professor Morris began his research career in the mid-1990s with work on uterine fibroids and has practiced extensively as a gynecologist in this field. We then have Amina Salar, and thank you very much for the lovely presentation before. We have Dr. Marianne Ledingham, who represents the National Institute of Clinical Excellence, where she's a senior leader and a consultant clinical advisor. And finally, we have Dr. Sharon Dixon, who represents the Royal College of General Practitioners. She's a GP and an NIHR Doctoral Research Fellow at the University of Oxford.
So, good afternoon, everyone. Can you hear? Is the microphone working? Yes. So, first of all, we can't start panel 2 without reflecting on the fantastic contributions from our colleagues who contributed so generously with their personal experiences in panel 1. So thank you all so much again. And I think what that gave me was 2 take-home messages. First, the need to be heard. The fact that uterine fibroids are under-recognised, under-researched and under-resourced. And so that frames the questions that I'd now like to make a start with for our panel. And perhaps first we could return to Dr. Amina Salar. And thank you for your wonderful work describing what can be achieved with the Women's Health Hub that is primary care-led. And sort of 3 short questions, because I know that time will be against us, so we're going to keep the questions short and ask for short answers. Do you think that the time, and I'm going to be very specific here, for a fibroid diagnosis in your health hub compares more favourably to the national average of time for diagnosis?
Yes.
I mean,
you want me to elaborate? I mean, we can see people within a month, so therefore we can also do one-stop ultrasound, and if they need hysteroscopy and MRIs, it's a very short wait time. So people will get key diagnostics quite quickly. The issue is so coming forward in the first place and being heard and referred, and then sitting on waiting lists to be seen somewhere. So yes, within our service, it's all about efficiencies of getting people to what they need to quickly. That's how it was designed.
Well, it's very impressive, and congratulations. And I think that many of us who work perhaps across the UK could learn so much from your model. Just keeping with your Women's Health Hub, you invited a question about holistic care and acknowledged that was something where more work was to be done. Do you want to just add a little bit more on that?
Yeah, of course. I think panel one alluded to it really well, probably better than I can articulate, but there's lots of gaps in research, in diet, in impacts on mental health, impacts on fibroids and various other aspects of physical life that we're unaware of. And then that's the initial starting point, gaps in knowledge, and then there's gaps in service provision as a result of that. Almost two separate but married to each other. So if I then translate that as a provider of a service, I'm asked, as are many of the doctors in this room, to deliver a certain amount of care, and that is ring-fenced almost. And I'll be very clear on what I mean by that. I wish I could do more, but I don't have the skill set nor the people around me within the service, because we've been built in a very sort of traditional way in that although we've innovated in doing things quickly, we haven't innovated in matching what people need and being as holistic as we'd like to be. I hope that makes sense.
So I am coming to other members of the panel, but I just have one more question for you, please, because you did allude to the word research. So I've been a clinical researcher for many years, and I feel that these women's health hubs could provide us with an opportunity. So what do you feel about the Women's Health Hub as being a forum for working with the research community? Not only will that raise awareness, but it will help our participant recruitment, whatever form of research that takes.
Yeah.
And I'd love to think that if I had a clinical trial, could I have your Women's Health Hub as one of my sites, please?
Yeah, please do. Please do. Yeah, welcome that. Yes, we work with innovators, researchers. We've just completed the Sonata trial in early diagnostics with Prof. Sudhasundar in early diagnostics of ovarian cancer. So trying to bring out, again, an integrated pathway in ovarian cancer right from get-go through to surgery. So we love to be able to do more research. You're absolutely right, it's well placed. If you think about the 10-year plan, if you think about prevention and early, it needs to be out in the community, and primary care needs to be working alongside researchers and secondary care to enable that. We have large cohorts of population, large amounts of data, that's not the issue. The issue is tapping into that and being focused about how we glean that data into meaningful outcomes that's evidence-based and is representative of populations.
Yeah, because I think that's so important. Yeah. Too many of our research studies are not sufficiently broad in who is included. So thank you. So can I now move to some questions for, and I'm going to pose one question, but invite Prof. Sukar, who's representing the GMC here, Professor Eddie Morris, who is representing NHS East of England, and Sharon Dixon, who is representing the RCGP, and I hope I'm correct in that, Sharon. So the question is a very broad question. I think we heard education, education, education from panel one. And so, given that we are all in this room aware that uterine fibroids are under-recognised, do you think, and if you do think it a mandatory part of undergraduate and postgraduate curricula, we could ask a separate question about schools and earlier education. But let's start with training our doctors, our healthcare providers of the future. How do you think we should be ensuring that this aspect of women's health is included? And maybe we could go, I'll just go along the line. So I'm looking at our first panelist, Sue Carr, if I may.
Thank you. I think that's switched on, isn't it? Yeah. If I could just join you in your thanks to the people who spoke earlier, as I really appreciated the passionate stories that you shared with us, so thank you for that. Coming to the question, so I represent the General Medical Council. So the GMC is the regulator of doctors, physicians associates and anaesthesia associates in the UK, as you know. And so we have the remit to set the professional standards for doctors, and we do that through our good medical practice guidance. And in addition, we set the sort of high-level standards for education and training. So for medical schools, we do set the high-level outcomes that describe in a broad sense of what you need to be to become a doctor in the UK. What we don't do is set the very detailed level of, what subjects need to be taught and when. But we've really strengthened our involvement in that area of undergraduate education in that a couple of years ago we brought in a medical licensing assessment. So now, for the last year or so, all doctors who qualify in the UK need to pass this assessment, and the GMC has developed a content map. So now that map, we don't set the questions, but we set the presentations and the topics, and within that are topics around women's health, and that includes fibroids and other conditions, and you can refer to that, it's published online. So we have really strengthened the assessment of undergraduate sort of knowledge in that way, and that assessment also applies to doctors who are new to the UK, whose assessment uses the same content map. In terms of postgraduate education, again, we set the standards as the GMC. We don't write the curricula because we're not knowledge experts, but we do approve the curricula that the colleges write, and we do that in association with the UK statutory education body. So they guide us as to what's relevant and feasible for doctors to learn in the UK. We also set what we call the generic capabilities for doctors, so those professional skills around communication, around patient safety, etc., and they're all embedded in those curricula. And then we also sort of work with other organisations to quality assure that education. So I think it's important to say the GMC really recognise and we're aware that there needs to be more focus on women's health issue, and I say we're working hard to do that with the MLA content map, and we're doing a review of our education standards framework at the moment, and that is listening to women and other, all other groups as we work to do that. So we really recognise that, but hopefully that outlines. We work as part of a complex system. I think that's been referred to a few times today. So the GMC has certain levers and powers that we can use, but mainly we work in association with all the other organisations, like the colleges, etc. Thanks.
Can I just be brave and say women are 51% of the population? We've seen the figures, 70 to 80% will have fibroids, and 1 in 2 will have heavy bleeding. If that isn't meant to be right up there on your curriculum, so I'd like to understand.
It's not our curriculum. That's the point. But
no, but that needs to go back to your people who write their.
I think that's right. But to say it's not our curriculum, and it is in our the power that we have to set a content map for assessment. It is in the MLA content map, but the curriculum is written by the specialists.
We just need the reassurance, please. Eddie.
Thank you. Thank you very much. Well, yes, also thank you for the invitation. It's great to be in a room with women with lived experience of fibroids. The first time I experienced that was 30 years ago as a junior trainee, starting my life in research. Yes, so from an education perspective, and certainly from the college perspective, I was lucky to be part of the first RCOG National Undergraduate Curriculum writing. I think you were on that group as well, Hilary, if I remember rightly. Maybe you weren't. Maybe I'm thinking of someone else, but never mind. Nonetheless, within that curriculum, which is guiding medical schools, the areas of obs and gynae that should be taught to medical students, and one of my big worries about medical student training nowadays, especially women's health, is it's now about a quarter, probably about half of what it used to be time-wise. Certainly my own University of East Anglia, that's a real problem. We've got contracting time that students get to learn about women's health. So that is a real issue. But also the curriculum that the RCOG wrote to guide medical schools isn't mandatory. It contains important issues all around women's health, including fibroids, but it is not one of those areas that is mandated. So medical students can choose whether they wish to use it or not. And so perhaps that's a useful lever for the future. As you said, Sue, the RCOG writes the curricula for postgraduate training. So we have the DRCOG, which is for GPs, and I'll leave that to my colleague to talk about in a minute, but also the MRCOG for people who wish to go into obstetrics and gynaecology as a career. And that's the full gamut of education around the pathology, the diagnosis, the treatment, the management of fibroids. And that's kept under regular review. And I guess that's the training of our future specialists in this area. In preparation for this talk, I did a little bit of homework over what sort of education other healthcare professionals get, because in my current role, I'm not just medics, I'm all sorts of other healthcare professionals. We have to think about what training do they get. So in the nursing education, there's education in menstrual disorders, and very similar for midwives. There's nothing specific about fibroids as far as I could find within the nursing curriculum. In midwifery, the effects of fibroids on pregnancy is mentioned as something that is a learning objective. And the only other place I could find fibroids mentioned specifically was that for sonographers. So our radiography colleagues who are doing sonography, they have fibroid diagnosis as part of their core competencies. So my feeling is that it's there in curricula. As you say, Hilary, it doesn't have the priority that it needs. I would say that from the RCOG, I think from an MRCOG perspective, it's something that has to be regularly updated. I think we've heard this morning it needs to include more holistic approaches to the effects of fibroids on a woman's life, to correct racial biases, which is a key direction the college is taking at the moment. So I think I know my answer there, if that's all right, Hilary, but happily to be lent on appropriately.
That's lovely. So let me invite Sharon Dixon. And remember, this was a broad question about undergraduate and postgraduate curricula.
Is that working? Yeah, so thank you very much. I'm also very, very glad to be here, and I also just want to say a massive thank you for the privilege of hearing the start of this session, which is why we're all here. And I'm really grateful for the chance, and also to have this space to have kind of collective, collaborative, bringing our heads together and sharing some wisdom to think of a really constructive way forwards, and it's such a great opportunity. And I was also really struck by what people have been saying about this journey starting throughout the whole life course. And of course, what we do as GPs is we hold, ideally, people, we support them through their whole journey through life, starting from childhood through to adolescence, through the whole life arc. And I have heard also what people are saying about young people's difficult experiences with menstruation starting then. I'm actually, in my research life, I'm just pulling together a lived experience resource for young people about their experiences of working out what their periods are like, heavy periods, painful periods, and going to use their voices to try and create their words, evidence and support that will help GPs, because I think we do need to start this with education in schools. But when we tell young people in schools that they should see their GP, I want to make sure that what they get when they get there is kind, is supportive, has the facts in a way that will make sense to them, and that it picks up the things that are important to them. I do think education is absolutely the key, and awareness, and I think that I'm so grateful as a doctor to get the chance to hear people's experiences so that I can try to learn how we can do things differently and better. But I do think if we're going to raise awareness, we do need a whole system response, because if you're going to raise awareness, you need services. I've been feeling very jealous of Amana's clinic, because that is not an experience that I would necessarily have where I work. So I guess one thing to say is there has been a really good evaluation of women's health hubs. I think you described such a beautiful and awe-inspiring example of what it can be. But they aren't one thing. They're commissioned differently in different localities. They have different functions. They sit in different places, staffed by different people. So I think just we've got a lot to learn from Amana about trying to improve systems, but I can't refer someone for a scan quickly, and I can't prescribe Raico, and I actually can't request a pelvic ultrasound scan just for heavy bleeding in my locality. It has to be pain, and I can't get anyone seen within a year or two. So education and awareness raising amongst professionals is absolutely pivotal, and there is a whole ton of holding symptoms, understanding personal priorities, holistic care, and holding the person in the room that I do believe that GPs can and often do, and that we certainly aspire to do. But if we raise our awareness, and we absolutely should, about which fibroids we can refer early and how we can make care pathways better, then it would be my plea to say, please, could we have services to refer into, and we have a whole kind of system longitudinal approach.
Thank you so much. And I think you raised some really important points there. And there's no doubt, listening to the stories we heard, if we had every medical student or postgraduate hear those stories, we talked over coffee, they would remember that far more than they would remember the chapter in the book. So I think you know, that model that you're describing sounds really important. I think that resources has come up, and again, maybe I could ask each member of the panel, and Marianne, I'm not forgetting you to get your moment as well. But in your experiences, which resources do you feel are the most, or a helpful guide to consultations, whoever is, you know, giving those in the area of fibroids? And perhaps maybe we'll start with Sharon and move along, Marianne, and then Amina, and then Eddie, and then Sue, but probably quite swiftly, because I do want to have time for a particular question for Marianne from NICE.
I would say that the best educational resource that I've ever encountered are the people I'm lucky enough to talk to in my clinic room, and that I think that learning and hearing from the people we care for and our patients is massive. I think learning from our colleagues is really helpful, and one of the great strengths of a Women's Health Hub is the potential for kind of bi-directional learning. We did a bit of research about supporting women's health in primary care, and the kind of bringing specialists or gynecologists and GPs together and creating those conversations where we can all learn from each other with the expertise we have. I think that's a really good resource. I would really like better evidence, and then evidence-based pathways about specifics. What size fibroid? When can I refer? What can I do? Which treatment's best for what? How quickly can I do what? That will help me get going and get started. I would welcome guidance and guidelines and evidence for those, and I would like evidence that gets me to scans and tests and treatment more quickly.
So I think that actually is a pathway to the question I was going to ask Marianne, and that is around NICE and its guidelines on fibroids and where we are with those. Are they due for some updating? Because I think that people do turn to guidelines as informing pathways.
Thank you, Hilary. I think you're absolutely right. In clinical practice, we rely very much on guidelines in order to direct care of our patients. From a NICE perspective, although there isn't one specific fibroid guideline, there are actually a number of guidelines which concentrate on the diagnosis and the management of fibroids. And these include the heavy menstrual bleeding guideline, and also the technology appraisals on Linzagilix and Rilgilix, which I can't pronounce, sorry. And at the moment, NICE is considering an update of some interventional procedures guidelines relating to transcervical and transvaginal treatment with radiofrequency ablation. There is always an opportunity for guidelines to be refreshed and updated, and I think it's important that NICE responds to feedback from its external stakeholders, and particularly from patient groups, as I've heard today, and I'll certainly be taking a lot of that information back to the organisation. But in terms of updates to the guidance, we rely very much on our surveillance process, where randomised control trials and evidence and patient safety is looked at on a regular basis by our surveillance team, but we also welcome very much input from external stakeholders. Individuals can directly come through the front door and ask questions of NICE in terms of is there something that we feel that needs to be updated, and there is also the opportunity for patient safety issues to be addressed through the front door by that mechanism as well. I think there is a lot of information and guidance that is already there within the system, and I personally would call for a joined up approach to the guidance that is there through national pathways, working with other organisations like the RCOG. And NICE, I think this has come at a very opportune moment for NICE because they are actively looking to engage with external stakeholders in order to implement the guidelines into clinical practice.
Just very quickly, because we have such wonderful lived experience in the room, can you remind us on a NICE guideline panel, and I say please remind us because we probably should know, what is the opportunity for the lived experience contribution? Because it is now mandatory on many research funding applications because the guidelines are for the people that we've heard the stories from today.
So absolutely, we would greatly welcome input from patient groups, charitable organisations, people with lived experience. There are opportunities to be involved in NICE guideline development as part of our committees, and individuals can be appointed to the committees as part of the NICE process and guideline development. Individuals are then able to bring their own lived experience to that process, starting right at the very beginning from the development through scoping, through to production of guidelines, and also at the point of responding to the recommendations that are made in guidance directly on the website as an external stakeholder. It's usually best for organisations to respond as part of that stakeholder process rather than as individuals, because by that process there will be published recommendations or published responses to those stakeholder questions on the website. Individuals can also put their own questions to NICE as part of that stakeholder process, but those responses aren't necessarily published on the website, so they don't in general have such a big system impact as an organisation approaching NICE as a body or as a group.
So thank you. I think that's very helpful, and I'm sure those opportunities have been heard by our audience. So let's just very quickly return to that question around what the other three panel members feel about resources that might be helpful to guide consultations on fibroids. And I'm being specific here about fibroids. Amina, Eddie, and then Sue, please.
I had an opportunity to have a focus group regarding, I'll slightly go off on a tangent, but bear with me, with a group of women who were talking about eating behaviours and their health. And one of the things that struck me is they said, it's great to have people with lived experience who are going through it, who understand and can speak in my language, and that I can actually follow with them in a peer group. I don't need a healthcare professional, a GP, nurse to talk to me about eating or diet or weight or whatever. And it strikes me that as healthcare professionals, we keep thinking that we are able to reach our communities, and sometimes we can, but actually quite a lot of the time, I think that we need those people from voluntary sector, peers, people with lived experience to provide that resource for us and to reach communities that we cannot reach. After nearly 20 years in Aston and Handsworth, if somebody asked me what are the key ingredients to addressing health inequalities, I probably still could not give you an answer, Because although I am somebody that's been there for a while, am I trusted? Do I say the right things? Do I actually enable somebody to change their life and to advocate for themselves? I'm not sure. I hope that I'm a safe space in that moment, but you know, to think that we can be everything to somebody is not possible. So for me, resources, which would be fundamental, is in a consultation. We have trusted resource in for different populations in different languages. I think the second thing is, I'm sorry if I labour that point, but I think it's a really important one. And the second thing is a standardisation of care, whether you're a primary care clinician or whether you're a secondary care clinician or whether you're in London or Liverpool. I'd like to see fibroid care uniform across the whole of the UK.
Thank you. Eddie and then Sue, and then we're going to hand to Joya to open up for the audience.
Okay. I'll be as quick as possible. I mean, for me, my greatest resource is my ears. As towards a medical student, 90% of medicine is listening to the patient and understanding how it affects her. I always say her, you know, because obviously as a medical student you're trained in men as well, but I've worked for 35 years with women, so it's a bit ingrained in me. But listening and understanding what the problem is, but also, most importantly, how it affects her is, for me, utterly key to the conversation. And this is where, when you have something like a guideline, which, forgive me, Marianne, sometimes guidelines sound very dry, don't they? But where NICE have excelled recently, in my other area of gynaecology, which is menopause, is actually producing the really dry information from research, turning it into a guideline which is principally there for clinicians, but then into information that patients can use, but importantly, that helps clinicians to tailor the advice they give to women to help them navigate their journey through what we've heard in the early part of the day, what is a very, very complex problem of fibroids. It can affect women in so many different ways. And I think perhaps if I had an ask of NICE is just to produce some of the lovely decision aids that are there within the menopause guideline, specifically for fibroids, because then we'd have more informed clinicians and empower the women, as we talked about earlier. That would be a bit of a special request, Marianne.
Thank you, Eddie. I'm going to ask Sue, because I do want us to then pass to Joya for the audience questions.
Thank you. I'm just going to echo what Eddie's just said, really. I think, you know, from a GMC perspective in good medical practice, listening to patients is fundamental for doctors, and listening to patients' stories is absolutely key here. Listen to the patient in front of you. I think the other thing, I'd probably echo what we heard earlier about the importance of research. There's a gap that you've been talking about today, and I think, you know, the other way to improve care is to sort of, as doctors, to sort of engage in research, to promote those opportunities to women to get involved in research and to develop. And for, say, it's not directly a GMC's remit, but research is a part of every doctor's responsibility as well in some way.
Thank you. Well, thank you all so much on the panel. We're going to now go to questions from the audience, and Joy is going to navigate that, I think.
Yeah, so we have around 10 minutes, so we'll leave some question to the audience, if that's okay. And then I want 5 minutes for question for all the panelists here.
Thank you again. Sorry to labor the point about research. That's where that's my background. A bit of a long-winded sentence to come to the question. It is, in my opinion, not that there is not enough data. It's about the questions that we are asking of the data we have. Let me take an example. We have this wonderful 100,000 genome program that we had a decade ago. The aim of that project was, you know, rare diseases and what have you. Genomic data does not expire, nor does it change in the course of a decade. Why is there not an effort to go back to that data that is already available to ask the right questions when it comes to fibroids, for example, and other women's health issues? But that leads me to the question to the panel about education. what is the framework? What are the processes? What are the touch points between GMC, NICE, and any other organization that coordinates healthcare delivery in the UK in ensuring that the medical staff, the medical profession, is aware of the latest advancement in research, stem cell technologies, cell and gene therapies. To this day and age, we don't understand why stem cell technologies, for example, are not being actively pursued for endometriosis. You know, the science is there. How do we make sure that the people who deliver healthcare are aware of that science, are engaging with that science, and explain to their patients the opportunities that present with those technologies?
That is a complicated question. You can see you've stymied the panel. I mean, that's translational medicine at its best, isn't it? That's understanding and turning the science into clinical practice. And I think, you know, the gestation of drugs is often longer than the gestation of an elephant's pregnancy, isn't it? Many, many years. And I think when it comes to things like stem cell research and genomics, I think we're still trying to learn how to turn that into clinical practice. You know, it's producing research which provides the information and the data that can then be turned into guidance and sensible clinical practice. There's obviously safety frameworks around all of these. I mean, it's a very difficult question to answer, and it's probably the subject of many, many CEPT conferences. I don't know whether my chairs agree with that.
Just a very quick thing. I think it's a great question. And I'm just going to do a quick plug for guidelines, actually, because really good living, and you can have guidelines that are a bit more iterative and living guidelines, but NICE guidelines and the resources that they produce for clinicians are actually an excellent way in which we can keep up to date with evidence. And we do, just speaking quite specifically to the touchpoint question, we have annual appraisals, we set ourselves goals, we work in teams. It's imperfect, but I think there's some commitment. And then speaking slightly more broadly, and I should probably confess that I'm a qualitative researcher, so genomics is slightly beyond me. But in a general principle, I would say about research that there's maybe an opportunity here as well about doing research that doesn't speak to a scientific question, but that speaks to a meaningful question that matters to the people who are living with the condition and to the people who are trying to deliver care to them. So working in partnership across research, both in doing the research, conducting the research, and then disseminating the research. And I think that there's massive scope for that in fibroids specific and women's health more generally.
I'm very sorry. I have to stop the audience questions because we have one final question for all the panelists, and I'm conscious of time. So the question is, should we work towards a James Lind Alliance priority setting partnership, or PSP? So the JLA PSP is a non-profit initiative to identify the most important unanswered questions for patients, carers, and clinicians on a specific topic so that researchers, funders, and policymakers work towards those central issues. So there is one specific for endometriosis, and there is another one on problematic menstrual bleeding, which includes fibroids, but there is no one specific on uterine fibroids.
Thank you. I'm not sure that really the regulator would have a specific response to that, other than to say, that research is vital. It's how we sort of improve patient care. So if patients can input into developing the right research questions in this area, that will help to drive quality of care. But I don't think there's a role for the GMC in that per se. Thank you.
I'm going to briefly cast away my NHS England role here and just say absolutely. I mean, if endometriosis has one, I think definitely fibroids is right up there just from a profile perspective. But equally, the partnership brings together, as you say, Joya, patients, politicians, clinicians and researchers in an organised fashion. So I really would wholeheartedly support that.
can I say a massive plug for a Yes Please as well? I've had the privilege of being on a couple of James Lind PSPs, and they are just the most, it's like the chance we've got today, but you've got a whole day to really come together, but for people to set the research agenda about the things that are most important to them. I've just been lucky enough to be part of the Menopause James Lind Alliance PSP, and the questions that were brought up were about inequities, they were about justice, they were about democratising research and about getting what was important to people right up to the top of the research agenda and setting it for the world to hear. So I think fibroids would be amazing for this.
If nobody else on the panel is going to speak up the need for the JLA initiative, maybe I can, even though I'm a chair, just say something. Endometriosis is a diagnosis. The one that's due to come out very shortly, if not this week, next week I believe, it's high on the radar for publication, is the problematic menstrual bleeding. That is a symptom. So we really, really need one on uterine fibroids. And anybody who's been involved in the process, what the output is the top 10 questions that those who have the symptom or the diagnosis or the condition see as important for the research agenda. And that is then listened to by the funders. And there are funders now who will expect, if you are putting in a case for research, that you have looked at the James Lind Alliance top 10. They published the top 10, but the rest of the manuscript gives the prioritization below the top 10. So it doesn't mean that because your area isn't in the top 10, it's not seen as a priority, but it's the top 10 that get the sort of attention. But it is now being seen by funders that you are really listening to what is important for the people who are suffering with the condition or the symptom that the James Lind Alliance is addressing. So it is a funded opportunity. You know, it comes with resource and it comes with a team that then put the process in action. And we're just hearing that Sharon and Eddie, you've both been on these. I've too, and they are really, really worthwhile. And I don't know whether, Mariana, you want to add anything to that, because I'm sure on the panel, if we haven't had experience of it, we have certainly been aware of it, and it's really changed the landscape in other areas of clinical care.
I think that would be a fabulous opportunity for everyone who's invested in improving outcomes for women with fibroids to work together to advocate for a positive change, and I'd really welcome to be part of that.
I'm not going to put pressure on anyone, but there's a call for James Lind Alliance topics out at the moment.
So I have to stop the session. So thank you very much to the speakers, and thank you very much to our panelists. It's been great discussion and we all learned a lot. And I also wanted to say thank you to our invited guest. We have Emma Rose, who is the head of Women's Health Governance and Assurance, and he representing the Royal College of Midwives. And we have Dr. Jackie William, who is a senior midwifery advisor for education and co-chair for Parents and Carers Network Professional Practice, and it's representing the Nursing and Midwifery Council. So I will ask you to stay seated. We have 5 minutes where we are setting up for the next session, and then we will start right after. Thank you very much.
Thank you, everyone.
Mic check, 1, 2, testing. Yeah, so for me that's quite quiet. Then obviously, if someone, I had a guy that was standing like this, and obviously for that you can't max that out because you're just going to get it screeching. If someone's standing that far away, they're just going to firm it. You can go up a little bit, but it's not going to make a difference. But obviously, yeah, for this, it now is quite quiet.
Yeah.
So you'd want to turn it up a little bit when you get upstairs if someone's speaking from here. If it then goes to the panel and no one's here, I'll just turn this channel off.
Okay. Just by put the slide.
No, I don't know.
So,
I was just going to introduce it and let someone else start it.
okay.
Is that okay?
Yeah, I mean, all you do is just press it. But if we want, we can. I can ask Francesca to come up and do.
Oh, if you just show me, I'll come. Do you want me to stay here until it's over?
It's about 5 minutes long, isn't it? Yeah, it's about 5.5 minutes.
Okay. Okay.
So if you're holding it, this is on. So if you're holding this, it goes up this way. To go next, you press the down. So some people hold it this way, but if you hold it this way, press down.
And that'll start.
Video should. And you just press down again, it should start. So it'll go to the black screen.
Down twice.
Yeah, so once it goes to the black screen, it should go. And if not, one of us can.
Hopefully I won't miss that.
If we do, one of us can come up and try to help you, but set that up for now.
Okay. I'll do that. Okay.
No problem.
Ready?
Oh.
Ready to go? Start. Okay. Hello. Hi. Hello. Hi. Hello, everyone. We're ready to start our next session on policy. In the US, we are not great about keeping time, and I have great respect for what I've seen thus far today, that everything has been very timely, so I'm joining that modality and trying to do the same. Hello, I'm Satiria Venable, founder and CEO of the Fibroid Foundation, and it is just truly a privilege to be here. I want to thank Priscilla and the entire Cambridge Fibroid team for just an outstanding day. And it's just been such an honor and privilege to partner with all of you. It's just, the panels have just been tremendous. So congratulations on just an outstanding day of advocacy. So just to provide some background before I introduce Congresswoman Clark, in 2019, pre-pandemic, we decided to blitz Capitol Hill with, we did about 8 to 10 meetings a day going to offices of different members of Congress. And it was me, a physician, and an advocate from one of our pharma partners talking about fibroids. Some of the office members said, come on in, we have fibroids, many of the staffers. For the offices where there was not that receptivity on women's health, this is a little tip. I talked about military readiness, full disclosure. And it did work. It got people's attention. And so it was, we did this over a course of about 6 to 8 months. And then, of course, you know what happened in 2020. The whole world shut down. But much to my delight and surprise, Congresswoman Yvette Clarke did not let that stop her. She introduced the Fibroid Bill in March of 2020. And it's written to provide $150 million in fibroid research funding. And whenever people look at me like I'm crazy when I say that, I say there are 26 million reproductive age women in the United States with fibroids. So if you look at $150 million over 5 years, that's $1 per woman. And that's just the start. We need far, far, far more than that, and it needs to be an annual funding that takes place above and beyond the 30 million per year that 150 million would advocate. So I'm not ashamed to be very direct and just really frank about really replicating funding that matches the size of the community impacted. And so with that, Congresswoman Clarke took the lead. Her dear friend, the late Congresswoman Stephanie Tubbs Jones, introduced legislation in the early 2000s. They both have been very vocal about their personal struggles with uterine fibroids. And Congresswoman Clarke represents the Brooklyn area of New York City. She's a fierce advocate, not just on women's health, but many other topics as well. And so I hope that you will enjoy this video from her as she discusses her passion and purpose behind supporting and introducing several key pieces of uterine fibroid legislation. Greetings, everyone. I'm Congresswoman Yvette D. Clarke, Chair of the Congressional Black Caucus, Co-Chair of the Black Women and Girls Caucus, and proud representative of New York's 9th Congressional District, covering Central and Southwest Brooklyn. I want to thank Homerton College, University of Cambridge, for extending this invitation to greet you and to speak on uterine fibroids, such an important issue in women's health. Although I cannot be with you in person, I recognize the urgency and significance of this symposium, Breaking the Silence about Uterine Fibroids, a pathway to legislative change.
This theme could not be more timely for meeting the moment. For far too long, uterine fibroids have been overlooked, misunderstood, and underfunded. Despite affecting an estimated 70 to 80% of women globally, fibroids remain overlooked in both public discourse and clinical care. This silence has consequences. With delayed diagnoses, limited treatment options, and unnecessary suffering, all women with fibroids, particularly Black and brown women, who are disproportionately impacted, can experience serious health complications that significantly impact their quality of life and can leave them with a feeling of hopelessness. I am deeply humbled to address you from across the pond as a member of the United States House of Representatives. In Congress, my mission is clear: to confront the disparities harming our communities, to advance equitable health care, and to highlight the maternal and women's health issues that too often go ignored. As co-chair of the Caucus on Black Women and Girls, I'm committed to ensuring that the health needs of Black women are not just acknowledged, but prioritized. That commitment is why I reintroduced the Uterine Fibroid Research and Education Act. Millions of women in the United States live with fibroids, and Black women experience them earlier, more severely, and with fewer effective treatment options. More research is needed to have a clearer picture of the devastating impact fibroids have on women of all ethnicities. I introduced a groundbreaking legislative package along with some of my colleagues aimed at advancing uterine health legislation. The Stephanie Tubbs Jones Uterine Fibroid Research and Education Act, the Uterine Fibroid Intervention and Gynecological Health Treatment Act, UFIGHT, the Uterine Cancer Study Act, and the Uterine Fibroids Awareness Month Resolution. This legislation is crucial to increasing federal investment in research and public education to reverse inequities in women's health. In addition, I've introduced the Menopause Research and Equity Act. The menopause is a natural phase of life, yet the challenges women face during this transition are often dismissed or ignored, especially for women of color. A woman's value is not defined by her reproductive years, and our policies must reflect that truth. Women should not suffer through menstrual health symptoms, but thrive with dignity and support and access to quality health care. The work you are doing through this symposium, alongside partners like the Center for Science and Policy, University of Cambridge, the Caribbean African Health Network, and the Fibroid Forum UK, is critical. Bringing together leaders from institutions such as the Royal College of Obstetricians and Gynaecologists, the Royal College of General Practitioners, and the National Institute for Health and Care Excellence, NICE, demonstrates the kind of cross-sector collaboration needed to drive real change. I also want to recognize the global leadership represented here today, including advocates like Satiria Venerable and Samira Rafaela, whose work continues to push this issue forward on the international stage. Together, we have an opportunity to ensure that uterine fibroids are no longer sidelined in health policy. Whether in the United States, the United Kingdom, or beyond, we must push for stronger research, earlier diagnosis, better treatment options, and greater awareness. In closing, I remain committed to using my platform to advocate for women whose voices are too often unheard in the exam room and beyond. Women's health care must be prioritized, and I will continue to fight to make that a reality. Thank you for your leadership, your partnership, and your dedication to service, breaking the silence. Thank you once again.
Thank you very much, Satiria, and thank you so much to Congresswoman Clark. I'm sorry that she's not here to address us, but actually she's been fantastic acknowledging this problem of uterine fibroids. Next, we are delighted to have in person Professor Dame Leslie Regan. Professor Dame Leslie Regan is a world-renowned professor of obstetrics and gynecology. She was the first woman in 64 years to become the president of the Royal College of Obstetrics and Gynaecology. And currently, she's the first woman to be the women's ambassador for women's health for England. Lately, she's been working tirelessly to deliver a revised women's health strategy for the government. And I think last month actually, she's just published this revised strategy. So please join me in welcoming Professor Dame Leslie Regan.
Just Leslie's fine, thank you very much. Thank you. So, thank you very much indeed for your warm welcome. And I've been in transit, so I'm really glad I'm here. And uncharacteristically, I arrived early, which is just as well, because you're running a little bit early. So the stars are aligning. So I've been asked to talk a little bit about the Women's Health Strategy, and I'm going to put it into context, I hope, for you. So for any of you naysayers, but I think I'm probably preaching to the converted, the reason why we need a Women's Health Strategy, and I've just come back from Harvard to explain why the US needs a Women's Health Strategy, is because women hold up half the sky. Now, this Chinese proverb was definitely constructed by a man, because it's a great underestimate. Women do a lot more than hold up half the sky. They're 51% of the population, 49% of the paid workforce, but they undertake more than 2/3 of all the unpaid caring roles in our society. They are responsible for 80% of all household health decisions, and you will have to agree with me that they are responsible 100% for all human beings. So, well done, women. So, we're going to talk about a life course approach, because those of you whom I've worked with for a long time, and I can see some people in the front row who I have, we've really got to get away from this disease-based model and also to talking about conditions. We've actually got to base our healthcare around the ways in which women present to healthcare. You don't turn up one day and say, I've got uterine fibroids, or I've got endometriosis. You say, I've got painful heavy bleeding, or I can no longer do up my trousers because my tummy's expanding. So it's really important on this slide, which came out of the Better for Women report, published by the RCOG in 2019, to look at this life course and to see here that the really important things in women's lives are being HPV vaccinated, because cervical cancer is a preventable disease now, having menstrual health as a really important topic that everybody talks about. We've only just started to talk about it, because do you know of any other thing that happens or event that happens to a human being, men or women for that matter, more commonly than having 12 periods a year for 40 years of your life? And I mention that because actually only 4 out of 5 women nowadays will become mothers, some because they can't, some because they choose not to. And we have historically looked at women's health as being maternity, and there is so much more to it than maternity. Most of the women in this room, even if they've had the sort of problems that have come to see myself, or Dr. Critchley I can see in the front row, or Professor Critchley, will not be pregnant for more than a couple of years of their lives. And my twin daughters, who are in their 30s, are going to be the first generation of women who's going to live longer post-reproductive than they were reproductive. So we've got to think a lot more, and I hope you're going to say that this is now becoming an outdated slide, because it shouldn't finish at 60, should it? My daughters are going to live until they're nearly 100. So we've got to think about those things in women's post-reproductive life, which we've steadfastly ignored until now, the things that are really going to be important. And I don't mean cancer. Most of the women in this room will probably, if I ask them, say, oh, they think they're going to die of cancer, depending on your family history, breast cancer or colon cancer. And you're wrong. More than half of the women in this room are going to die of heart disease. Another proportion, and some of them have both, will have osteoporosis and the complications of frailty and or dementia. Asked often what I'd like to have first, I think I'll go for the dementia, because then it won't be quite my problem, really. But I jest. Remember that when I came out of medical school, not only did this finish at 60, but women disappeared from view at 50 because they were menopausal, they were no longer reproductive. So we've got to change our horizons, and I don't think our NHS has got hold of this yet, and we've got to be persuading them that we've got to do this. Now, the Women's Health Strategy for England, this resulted from a public consultation about women's health, which I like to think was probably triggered by that Better for Women report back in 2019. We then had a sort of interruption with COVID and the lockdown. Lots of good things happened in COVID to show us that we could do things differently if we were willing to try to do them differently. And the Department of Health and Social Care launched this public consultation in 2021 with the expectation of publishing the outcome in a few months. Well, it took them a lot longer than that. It didn't get published in the end until summer of 2022 because no less than 100,000 women wrote in. Now, they didn't write in a couple of sentences. They wrote in pages and pages about how fed up they were with the NHS, how the system had ignored them, dismissed them, disbelieved them, gaslit them. Anyway, it was eventually published in the summer of 2022, and I was appointed a little bit earlier that year, setting out a 10-year plan. A lot of people say, well, 10 years? What's going to take? And I said, I'm not prepared to be involved in a plan that's less than that because you can't tackle everything in year one. Well, you can't get everything over the line in year one. And this needs to be a dedicated framework for reshaping how we look at 51% of the population going forward. So the broad principles were to improve the health outcomes of women and girls and reduce disparities and improve how the healthcare system listens to women. And I really mean listens to them and hears them as opposed to going through those tick box of co-production by showing somebody something and saying, right, I've shown it to someone, so we've co-produced it. That's not what co-production is. So 84% of those 100,000 women who wrote in, who were very cross, told us that they had been ignored. So that's a very, very large proportion. Now, I've chosen to show you this, not because I'm going to go through the whole strategy, but these were the 7 priority areas when we published the strategy. And everyone was a bit surprised about this. Well, oh, the things that they thought would be the conditions weren't talked about. So menstrual health, I was really pleased to see, and gynecological conditions right at the top. So they're grouped, not in order of, grouped by order of importance as women told us. So the vast majority of women told us that they needed more help with their menstrual health and their gynae problems. And we can go down the list here. You'll see various other factors there. And what I want to just focus on just briefly is heavy menstrual bleeding. So I know that you've had various talks this morning, and I'm sorry that I wasn't here to participate in them, but hopefully I'm not going to duplicate too much. But it really is important, going back to my life course slide, that 1 in 3 gynecological outpatient referrals are for heavy or painful menstrual bleeding. It leaves 1 in 3 women iron deficient. And I really want to emphasize here that in a group of where we're talking about fibroids, it is very common to find women who are iron deficient with uterine fibroids. And you really do need to expand your diagnostic criteria here, because it's not measuring their hemoglobin, it's actually looking at their serum ferritin, which is their iron stores. So if you lose a little bit more iron every single month, once every 12 times a year, it's not long before you become iron deficient. And people are really unwell. Well, women are very unwell. They complain of tiredness, they're feeling washed out, they can't concentrate, they've got poor brain fog, unable to work. And the other telltale thing is, I usually say, and is your hair falling out? And invariably the girl or woman says to me, how did you know? Because when you've got low ferritin, your hair falls out. And not surprisingly, girls and women get very upset about that. And I just want to emphasize, before I move on to the rest of the strategy, how being iron deficient isn't just a problem for the woman who's iron deficient because of her periods and feeling tired. It's got an intergenerational challenge. And thank you to Hilary for this slide, because we put it in our vignette, didn't we, for Nature Medicine, of how it affects women in pregnancy and complicates their pregnancy when they're iron deficient. The problem is then transferred to the fetus, who has impaired neurological development and sometimes growth restriction. Then the infants have got lower birth weight, higher mortality, impaired neurodevelopment, childhood, adolescence, and adulthood. So plug for iron deficiency, always check their ferritin. Don't just rely on a hemoglobin. So in years 1 to 3 of the Women's Health Strategy, we're in year 4 now, we encouraged, well, we did a lot of things. I'm not going to go through them all. I'm just going to say a little bit about the Women's Health Hubs, because some of you may have heard me talking about Women's Health Hubs before. And here we're talking not necessarily about a place-based model. We're talking about a concept where we wrap services around women rather than make the women run around lots of different services to get what they could easily focus on, access in a single appointment if the services were designed with women in mind, not the payment by results model that we have in the current NHS. And one of the reasons why we wanted to do this, and this report came out from the RCOG in November 2024, which was year 3, was that there are very, very large gynaecology waiting lists. Now, NHS England used to say to me, well, it's the fifth priority. And I said, well, it must be higher up on the priority list than that, because what other disorders in your list only affects women? Silence, but they wouldn't move it from number 5. I reckon it's number 2. Anyway, at the same time as Rani Thacker published this report with the RCOG and commented that if we put all the women on the gynae waiting list across the UK in a line, shoulder to shoulder, they would queue from London to Exeter, which if anyone's been to Exeter recently, I have. It's a long, long way. And then at the same time, Sue Mann and I, who's my counterpart at NHS England, the first ever National Clinical Director in Women's Health, they've got masses of people in maternity, but nobody in women's health until Sue arrived 2 years ago. Baroness Merron asked the two of us to do a deep dive into the gynae waiting list in England and Wales. And on it, we found 600,000 women waiting for gynecological care in secondary care. And let me tell you that 85% of those 600,000 were not going to have any form of invasive procedure or an admission for a day surgery or inpatient care. So I hope you're saying to me, well, what the hell are they doing on this waiting list then? Just getting worse while they're waiting. And of course, many of these women were waiting 18 months or 24 months before being seen. So that was the point, November 24, when Sue and I said, look, we've got to stop admiring this problem. You know, we have a great tendency in medicine, don't we, to admire the problem and write another report. Let's actually stop admiring the problem and let's take some action and to change this. And this came about in the aftermath, if you like, of the publication of the NHS 10-year plan. And you will all have been had this rammed down your throat so many times about the 3 important shifts: to go from hospital to community, from analog to digital, and from disease model to prevention. And I'm trying to emphasize here that this isn't just a bit of tinkering around the edges. This isn't Leslie Regan doing a few more outpatient hysteroscopies or surgical procedures and day surgery or seeing more patients or going to another MDT. This is about having a radical left shift. So we've got to move away from this secondary care disease-based model to primary care, and we've got to upskill the people in primary care. Now, please note, I'm not going to use the word general practitioners because they get very upset about that, and I don't believe it should just be GPs. It's people like me who should be going out into primary care and community clinics to help train and teach and see patients where it is convenient for them. Community diagnostics, really important, and then community prevention, information, and self-management. So if there's one thing you get from this, not tinkering around the edges, this is a massive shift, and it's going to require everybody to be willing to try to do things differently. So I think that you will gather that I'm not going to tell you that they don't work, am I, women's health hubs? They're now being changed, the nomenclature. Then they became community hubs, and now the model that we talk about is neighbourhood health hubs. Quite frankly, I don't care what we call them, as long as the principle of wrapping services around women closer to home is followed. And I think it would be reasonable to say that, yes, you can look at that. It reduces waiting lists, it improves access to preventative care, reduces pressure, short and long-term NHS savings. But I think those 5 categories of patient or woman do not need to go to secondary care in the first instance for contraception and LARC provision, cervical screening and treatment, menstrual health management, and here we've got fibroids, adenomyosis, endometriosis. And I'm really glad it's menstrual health management, not, as many ministers said to me, well, we've got to do something about endometriosis. And no, you don't wake up with that, as I was saying earlier. you get your endometriosis or you get your intolerable fibroid symptoms because your painful heavy periods haven't been listened to or haven't been dealt with. And then pessary fitting removal, incontinence advice, menopause assessment and treatment. All of this needs to be done. It's high volume, low acuity most of the time in primary care or in the community, and then only those cases that are intractable to go into secondary care. So let's fast forward, and here's Wes Streeting talking to Rane Thacker. Some of you may have been at this Congress last June 2025, and he was talking about the 10-year plan and the 3 shifts that I've said. And then one of the questions, well, what about the women's health hubs? And of course, without any consultation with anyone, let alone a special advisor, he said, oh, no problem about that, he said. I've asked Dame Leslie to refresh it. And then immediately all the spads were on the, has he asked you to do this? I said, well, yes, I'm sure he has. Yeah, don't worry, we're going to refresh it, because, you know, you must never, ever look an opportunity and turn it down, because opportunities give you great things, always a success story somewhere. So I think we've made progress. I'm sure that many of you are here because you're passionate about the fact you haven't been well looked after in the health service. But I think this is a pivotal moment, and we now need everybody to take the learning we've had from the last 3 to 4 years, and we've got better models for many things. At least we're talking about all these things now, even if we haven't resolved them. So we've got to remember that these are predictable health events for women, and therefore for them to be neglected is madness. So I think it's a chance to travel farther and faster and to be more ambitious. And when I talk about closing the gender health gap, I'm not just talking about between men and women, I'm talking about among and within women who are experiencing the very worst health inequalities. So fast forward now, it's April the 15th, so just 3 weeks ago tomorrow, I think it is. And there we are, renewing this women's health strategy. And you'll see Wes Streeting there and myself launching forth about something. And the 4 key outcomes that I've distilled from a report, I'm trying to make it life easy for you because there's 117 action points. Don't worry, I'm not going to go through them all. So 4 key outcomes: ensuring that women's voices are central in the healthcare design and delivery, transforming performance in services that matter most to women, not what I think women need, but what they tell us they need, support women to lead healthy, prosperous lives, and then create research and development that works for women. And by that I mean not just women in trials, but also women leaders in research, because if you haven't got people that you can look up to, you're not going to recruit people who are wanting to do those things. And here I've distilled of the total 117 some key actions, because they are very practical things. So reducing variation in general practice using the GP patient survey data in EQUIP, an equality improvement program, developing standards of care for delivering gynae procedures, ensuring women have informed consent. You'd be surprised how many women tell me that they haven't had informed consent and they haven't been offered pain relief. And that's barbaric, isn't it? Support integrated care boards to introduce a single point of access, and that I think you might have heard from Amina earlier on about how if you have senior people triaging your referrals, then and multidisciplinary people doing that, not just doctors or nurses, but physios, incontinence advisors, all sorts of different people, you will be able to streamline them or direct them to the right place. And in places like Tower Hamlets, who have done that extremely well, they have reduced, and wait for it, they've reduced their secondary care referrals from 86% down to 26% by having a single point of access run by senior people. And I think the Birmingham model has got similarly wonderfully successful results. And redesigning the common clinical pathways, including heavy periods. And it started off as endometriosis, and I said, no, we've got to have heavy periods so that we include everybody who has a menstrual health problem. The other plans are to fund a specialist centre in each region for group-based approaches. So perhaps in Cambridge, for example, you might have something for endometriosis or whatever. So high volume, low complexity women's health pathways. Femtech Healthcare Challenge, which I think is going to be difficult because there isn't any money to follow it, but we will have to encourage people to do so. Expanding access to musculoskeletal hubs in the community using the leisure and fitness workforce, who I've been to talk to a couple of times in the last few weeks, who are really keen to contribute. And possibly most importantly, and this is thanks to Sue Mann's work, launching a publicly available women's health data dashboard. So you can go and look up what's going on in your patch, and you can hold your integrated care board or your trust to ransom about, look, this is what it's like here, and we're not doing well compared to, I don't know, East Yorkshire or whatever. So launch a program to improve education for girls about their menstrual health, and I think that's absolutely key, because I really believe it all starts with young people and teaching them what's normal and what they shouldn't be putting up with. Establishing a Women's Voices partnership so we don't have this situation again where people who look like me are telling other people who don't look like me what they need. Developing patient-reported experience measures, PREMs and PROMs, outcome measures over the next 5 years. And the one I'm not sure about, but I thought I would put it up there because you may have questions, is this idea that came out of nowhere just before it was published to pilot patient payments for gynaecology services, varying payments on women's feedback on their experiences. I mean, at first glance, yes, great idea, but you can see how that might actually be a perverse disincentive in some areas that actually need more resource. So, as I was saying, we're going to call them neighbourhood health models now, Women's Integrated Neighbourhood Services, or WINS. So the priority is to have at least one permanent physical venue within a neighbourhood, providing face-to-face intermediate care, and being the anchor point for this neighbourhood model. And integrating services, and then the neighbourhood model being the whole system approach to planning and coordinating and delivering services across a neighbourhood population. So the population in this area, in the Cambridgeshire or in the east of England, are going to be different from the needs in the northwest of the country or in the southwest. And then you can see all of the people that we were hoping be part of that neighbourhood care model. So it's Women's Integrated Neighbourhood Service side, neighbourhood pharmacists, GP practices, neighbourhood, and as I said, secondary care clinicians like me who are contributing to that model. This has got to be a major, major left shift. So why is that central, or why is neighbourhood working central? Because it enables care that's organised around the place and the population, so it can be different depending on what your population need. Integrating MDTs across the NHS and local authorities and the voluntary sector. I don't go anywhere without someone from a voluntary organisation or a charity saying, I want to contribute this. And yet we don't have a doorway for them to be able to knock on and say, how do I contribute this? We just sort of shut the door and pretend it's not there. So all of those things, key messages, you can't really deliver women's health ambitions inside fragmented pathways. We've got to have a seamless service, and I think that neighbourhood working will be there, that service there. So Suman and the NHSE team are working on good practice guides so that nobody has to start from scratch to work out what they need to do. And they're going to be new neighbourhood-based models to deliver women's healthcare, co-developed with system partners, so the ICBs, the NHS providers, the local authorities, the commissioners, and people with lived experience. And you can look there at all of those things. So they're going to replace the Women's Health Hub core spec with a model of neighbourhood-based care, which will include a lot of the things I've been talking about. But going forward, going to the point where, having sorted out all these reproductive, predictable things that girls and women need, we'll then be able to repurpose the funding that is saved on that into the things that are going to be troubling my daughters when I'm long since gone and they're living in their 90s or even earlier hundreds. So we've got to reframe this Women's Integrated Neighbourhood Service as an integrating organisation, not just as a service provider, and placing prevention and workforce development and population right on an equal footing. Okay, so for anyone who's not convinced, these are data from McKinsey, who are one of the major leading healthcare analysts globally, and very kindly reanalyzed just with UK data in mind. They presented this to the World Economic Forum in 2024 to much shock and amazement. But Lucy Perez, who's the senior analyst, then did this for me, and you can see here that if we close the gender health gap, and this is not just having fewer health conditions and fewer early deaths, but if we take all those women between the ages of 20 and 50 who are incapacitated by the various problems that they have, and we allow them to have an increase in productivity, and we expand participation, we will save 36 billion sterling every single year. And 36 billion sterling is about 20% of the current NHS budget. So there's an awful lot to be striving for here. I will just leave you with a thought that we must implement the Women's Health Strategy, whether it's going to be in a Women's Health Hub, a neighbourhood hub, everywhere, but because we need to get it better for women. And when we get it better for women, of course, as I was saying to you earlier, since they make all those household decisions and are responsible for the birth of every human, you get it better for everyone. And I'm going to keep bashing on the Treasury's door to say, and if we get this better for women, we can get it better for less money. And hopefully that argument will prevail. So thank you for listening so patiently.
Thank you very much to Professor Reagan. So my name is Jasmine Kiley. I am one of the Fibroids Free team members and a PhD student in the Department of Obs and Gynae here in Cambridge. And we are just now going to be moving into the panel session for our Pathways to Legislative Change session. So as we quickly get set up, I would just like to introduce the panelists who we will be seeing today. So Professor Dame Leslie Reagan will be joining us once more. And we will also be joined by Samira Raffaella, who is a visiting fellow at Cornell University and a former member of the European Parliament and prominent advocate for international human rights, gender equality, and social justice in the Netherlands and globally, particularly through her initiative and upcoming book, Let's Talk About Our Bodies. Satiria Venable will be joining us as well. She is the founder and CEO of the Fibroid Foundation based in the United States, where she has turned her personal health journey into a global movement for patient advocacy and uterine fibroid awareness. We'll also be joined by Dr. Michelle Griffin, who is an OBGYN and former research strategy leader at organizations such as Cancer Research UK and the WHO, and she is the founder of MFG Health, a healthcare consultancy firm focused on women's health. And finally, we are going to be joined by Professor Janine Reuters van Lennep, who is an internist specializing in cardiovascular gender medicine and the co-founder of the Netherlands Women's Health Research and Innovation Center at Erasmus MC Rotterdam. So without further ado, we'll commence our panel. We're very excited to have us all here today.
So can everybody hear me? Yeah, okay. So thank you very much, everybody, for joining this final session. I think I'll start with a question with Professor Dame Leslie Reagan. Okay, Leslie. So I really like the strategy because actually probably this is the first strategy that we have seen uterine fibroids actually feature quite a lot. And also, actually, I like the discussions that we had this morning. I think Sona is from, so she's from Black Mothers Matter. So she was talking about actually fibroids before women become pregnant, and then during pregnancy, and then how actually that affects pregnancy. So the question is actually, from this strategy, what is the scope actually of working, joining up the obstetrics and gynecologists and also GPs to make sure that actually you can follow up these women across, before they become pregnant, across pregnancy, and then later on after pregnancy, because we know that pregnancy complications actually also determines the woman's health after that. So is there a scope for that actually in this strategy?
Well, very much so, and thank you. It's a great question, Priscilla, because my point about the life course is that pregnancy is a very important part of a woman's life if she chooses to become a mother or can become a mother, but it's a very small time window. But as you said, the health of that woman as she goes into pregnancy is crucial, and then there are two patients there, or two recipients, the woman who will do poorly if she's got, for example, iron deficiency anemia, just as my example, or some other complication, and also the baby will have a poorer outcome. And then, as you rightly say, if you became preeclamptic or you had some problem like that, or you developed gestational diabetes, we know that you're going to get become a type 2 diabetic by the age of 50 probably, and that you're much more likely to have hypertension and cardiovascular disease 10 years earlier than your next door neighbour who didn't. Now, all the time I was an obstetrician, I would collect all this minutiae of data about these pregnant women, but the moment the baby's bottom hit the bed or got into the cot, everybody ignored everything else after that. And then the focus was always on the baby, or if the mother had a complication, fine. But you know, that's my point. So I believe strongly that, and I know I'm going a bit off message here, but the reason why we never seem to be able to get to the bottom of our maternity disasters is because we view maternity as a separate issue over there. It's got a different team, you know, nobody collaborates with each other with other parts of health. So, for example, you know, if in cardiovascular disease, the cardiovascular people are desperate to get their hands on women who've had problems in their 20s, 30s, and 40s. And we put so many barriers in their way. So let's use this, and this refresh strategy, if you look at the small print, actually talks quite a lot about cardiovascular disease, bone health, and mental health and dementia later on. So hopefully the next time we have a refresh, because I'm already angling for that, we'll be focusing very much on those longer term conditions.
Lovely, thank you. So moving on to a question for Sateria, actually. So we originally met last year in Congresswoman Clark's office, which was a really incredible experience. And from your experience working in the US, kind of frame it in the context of the UK, because here we need to consider whether legislative change happens at the level of the devolved nations versus the UK government as a whole. So from your work in the States, what have you found is the best balance of pushing for change at the local versus state versus national level?
Great question. So it is layered, and I've found that there can be effective change by tackling all of those entities separately, but also identifying where it's smart to have them collaborate. For example, there's an organization in the US called Women in Government, and we've presented to, it's an organization of state legislators, and we presented to them, and many of them talked about working from their bathtub because they were bleeding so heavily that they couldn't go to work. And so when you have a state legislator being that open and vulnerable and really understanding what our mission is in terms of advocacy, it speaks volumes to the communities that they serve directly, as well as the national members of Congress and the Senate, that they too can be vulnerable, they too can understand, that they too can join these conversations. So through our ambassador program, the ambassadors visit their members' offices, and so that's the community level that really resonates really deeply, because, you know, the representatives always want to know if their direct constituents are being impacted by a certain issue. And then on the national level, I found that one positive thing is that there are a lot of people who understand and are willing to address this, and I have not on making sure that no matter what we see on the national stage, I'm just a firebrand. We're just going to move ahead. We're just going to go ahead and make sure that we get the changes done that we need to get done, because this issue impacts communities. And the more that we understand that one thing that we need is to have everyone in the conversation, not just folks with a uterus. Like, everyone who does not have a uterus needs to understand that I think, Leslie, you talked about the opportunities. I'm always talking about the opportunity that is presented when women and menstruators feel better. Like, instead of us talking negatively about the experience, there's so much opportunity when we are thriving. And so those are the conversations that we need to have on all of those levels, Jasmine.
Thanks, Sateria. This is a question for Samira. So I think that the first time we met here, and you told me about the Soteria, that you have started collaborating with Soteria. So could you tell us about your collaboration a little bit, and how actually that has helped you as collaborators to transform this conversation nationally in the Netherlands, in the USA, and also globally?
Thank you very much. So I remembered the day that I was diagnosed with fibroids very well. I was by coincidence, actually. And I was surprised, caught off guard a bit, panicked also a bit. All these questions go through your mind. Even very deep, sensitive questions. Can I still become a mother? What are they going to do then? And so on. So when I started my own research on fibroids, I remembered, oh, wait. This was being told in my family. I remember my mother talking about, my grandmother. And then I started to talk about it with my own friends and my own environments. And I had two types of reactions. So the first was, oh yeah, I have this too. Very nonchalant, very as if, you know. And the other reaction was, what is that? So both responses, I thought, were worrying me. And I remembered another friend actually saying, you should go look up the Fibroid Foundation in DC. Because my fibroids started growing, and at a certain point they said, you'll need to go through surgery. So I found Fibroid Foundation and their Instagram page, and I got a lot of support from it. Because I saw very informative posts and information that I could also use for my own journey. So I realized that it is extremely important, and back then as a legislator, to bring in these patient voices to the spaces where decisions are being made, and that stories need to be told. So that's how I ended up launching also my own initiative, Let's Talk About Our Bodies, and my book in 2 weeks that will be out in the Netherlands called Let's Talk About Our Bodies, Breaking Through the Uterus Taboo, because I realized that if our stories are not being told, for example, through the Fibroid Foundation and so many other initiatives, that the legislators and the policymakers will not comprehend what we're going through. I also figured that during this journey, and we talked about it a lot, the reason why we need to tell these stories is because I believe one of the causes why we're not investing enough in women's health is because we don't talk about it enough. I discovered during my own journey and my research, also for my book, I've interviewed other women. It's not only my story in the book, it's also other women's stories. There's this journey of shame that we all go through. And everything that has to do with the uterus or hormones is covered by this layer of shame. As a former legislator, I know very well what you need to do to get attention is to make something a problem. It needs to become a problem. Someone in that room needs to decide, okay, this is a problem. But if we hide it and if we don't bring these women's voices to the decision-making table, then most of the policymakers and legislators will say, oh, is it a problem? So what I believe we have learned also through our own process is that bringing the women's voices to the legislative space is extremely crucial. We need to continue doing that. Legislation without implementation, and that's also what the Fibroid Foundation, but also the Dutch Fibroid Foundation, who is here with Leila as a founder, and so many other initiatives are trying to do, is that if we have legislation, but we don't have implementation, it's only good intentions. And women for too long have lived on good intentions, right? So we have all written it down in our treaties. Everyone deserves equal access to care. Everyone deserves good care and support, but it is not taken care of in practice. And another important thing, what we will look into also for the future, is the importance of funding and money. Because if we only have plans that stay on paper, you can even implement it, but then it will not do anything in practice. So for example, also here in the Netherlands, we figured that if we can solve the gender pay gap, so if we pay more attention to healthcare, we can benefit from it with 7.6 billion euros. That's a lot. But still, even though we have a national plan, a national strategy for women's health in the Netherlands, still we don't have enough money to make it a success. So these are the very next future steps that we're going to undertake and try to make policymakers and legislators understand that if you don't have money, if you don't put money in women's health, it's just not going to work. So I truly believe in the next movement of women that that will tell their stories, that will raise their voice and use their voice to impact policy. And I believe that's exactly what we have been talking about and what you've done so well also in the US, and that definitely needs to happen more in the EU. There's more attention now for the women's health strategy in the EU, but it's still not enough because there's a lack of money, there's a lack of women's voices sitting at the table, on the decision-making table. And I think what we can definitely learn from the US is the role and the position that legislators will take in this process. It's a lot of admiring, I totally agree. It's a lot of talking and emphasizing it is important, but we're not putting the money where our mouth is.
Thank you, Samira. So going along that idea of implementation and change on the ground, Janine, had a question for you, which is through your co-founding of the Erasmus MC Women's Health Research and Innovation Center, how are you ensuring that its main priorities and ongoing work are translated into concrete policy and that system level change that we've been talking about rather than remaining within academia?
Okay, hello, yeah, now it's working. Yeah, thank you very much. And indeed, from the start onwards, it was for us, it was very important that it was not just an academic exercise. And I think what really distinguishes our center is that it has really a holistic approach. It has, it's really life course based and also transdisciplinary. So I myself, I'm an internist, vascular medicine, kind of preventive cardiology. But we also work together with researchers, but also women with lived experiences. And we have very much connection with policymakers, but also with companies, femtech companies. And so we really want to have outreach. And we really tried also, because one of the main problems, and it's also what you hear here, is the silos in women's health. So we really want to connect women-specific factors to chronic conditions that disproportionately affect women or affect women differently, also have this life course approach, and also pay attention to the data gap in women. And because very often, if you go to the gynecologist, all those women-specific factors are important, but if you go to the cardiologist, they often don't ask about fibroids, even though, and that's also what we hear today, fibroids are not only a condition that affects the uterus, but also women with fibroids have a higher risk of hypertension and cardiovascular disease. And just to give you an example, we also focus on research and innovation. Innovation can be like technical innovation, but also care innovation. And together with an obstetrician, we founded a clinic, especially for women who had preeclampsia. And those women were followed up immediately postpartum, 6 weeks postpartum. They saw normally also the gynecologist, but the gynecologist would say, okay, you survived, your baby is okay, we'll see you back when you're pregnant again, if you're pregnant again. But we did this visit together, and then also 3 months after pregnancy, 1 year after pregnancy, and then every 2 years we saw them back until they were 50, and then we would refer them to the GP. We thought, well, maybe nobody shows up because, well, it's prevention, and those women are maybe so happy that they survived. But it was the other way around, because women from the whole of the Netherlands came to our clinic because we were the only multidisciplinary clinic. But then we, of course, in one center, we could not host like the whole of the Netherlands. So in the end, we have now a guideline in the Netherlands that also GPs And at first they were very reluctant because they were so busy anyway, but now they also committed themselves to have a follow-up program, especially for women with preeclampsia. On the other way around, I think that you could really extend that model also to women with fibroids. Why not measuring their blood pressure? Why don't we give them cardiovascular screening if you see them anyway? Well, that is in a nutshell something like how we think in our Women's Health Center.
Thank you, Janine. So now I have a question for Michelle. So Michelle, you've worked for national organisations such as the Cancer Research UK, and also you've worked for the WHO. So we know that several organisations such as the WHO and UNICEF, they set up strategies to sort out maternal health and also actually cardiovascular diseases and so on. But as far as I know, they have not discussed uterine fibroids anywhere. So could you just comment on that, of why uterine fibroids have not been discussed, because this is a global issue actually. And actually, where do we go from here to make sure that actually organisations like the WHO and UNICEF can do something about this?
Yes, thank you very much. So you're completely right. It's massively under-recognised, the role of fibroids when we look at guidelines across WHO, UNICEF, etc., with regard to maternal health outcomes, but also in women's health in general. Priorities are picked up, such as anemia, which Leslie and others have spoken about a lot today, along with things such as hemorrhage during childbirth. But what isn't picked up is that sort of layer below. What are the upstream drivers here, of which obviously fibroids is the major one? Why that hasn't been picked up, why it isn't explicit, isn't clear. I think it just needs to be more explicit, because what's getting lost in all of this guidance is just a focus on the outcomes, such as anemia, rather than what is the cause, what's the driver to anemia, and therefore what do we need to do with regard to prevention, screening, early detection to actually prevent getting to the point of anemia or major hemorrhage during delivery and postpartum, leading to severe blood loss and potentially death as well. So if we then look and say, actually, what happens if it was really explicit, if it was pulled out to be a priority, and we look at fibroids specifically, then we can look at other significant impact that has happened, such as political prioritization and funding, which we've just talked about on the panel here. And when it's pulled out by massive organizations such as World Health Organization, especially if it's then put on as a sustainable development goal, an SDG, then the whole global participation of countries is working towards that goal. And it just isn't explicit enough at the moment. But if it is pulled out, then I hope to see that we would see much more change with regard to funding and prioritisation.
Can I just follow up on that? So I'm glad actually you mentioned to be explicit about the issue. So who do you think at the moment will go to the WHO, for example, and UNICEF and be explicit about this?
That's a great question. I think where we've seen some significant sort of drive to change is actually patient advocacy, and the advocacy groups actually going forward. And I think we touched on it a moment ago about actually showing the real problem in the room. But I think probably that by itself isn't sufficient, sadly. And what it needs is political backing, and identification of the problem. But, there is always a sort of tussle for what is the most important, what's the priority. And Leslie, you said yourself that, having conversations with the government suggesting why is it number 5 when it should be much higher. I mean, this isn't something specific to the UK. It goes across the whole globe, especially in health. There is always a tussle about what is the number 1 priority. But the fact that we've already got a situation where WHO has called out anemia globally to be a significant priority. And just to put that into context, 30% of women in reproductive age are anemic, 37% who are pregnant globally are already anemic. You are just basically waiting for a car crash to happen of significant problems, and many maternal morbidities and maternal mortalities, along with the fact of massive problems pre-pregnancy and post-pregnancy in later life. So it just needs to be potentially more experts to sit there bringing along patient advocacy as well as political kind of prioritization to say we need to be more explicit here.
Thank you, Michelle.
Yes, thank you very much. So we'd now like to open it up to the floor for questions before we come back. So I see one here. Microphone's coming around.
Hi, is it working? Yeah. Thank you so much. It's been a really, really interesting panel. You've talked a lot about the role of politics in addressing this issue, but I was wondering what you thought about kind of how, like, the politicization of women's health, whether it's great and like it's perfect because then people are talking about it and then change can happen, or whether there's a bit of a danger there that making women's health a political tool kind of frames it in a way of like othering it, whereas it should just be the norm and what's expected because women are taxpayers. Women just deserve it anyway.
That's a really important question. I think one of the things we haven't talked about is what's really underlying this underfunding and lack of conversation on this topic. And that's a centuries-old stigma that women should suffer. And so, you know, we started the Fibroid Foundation with the intention of really looking at fibroid advocacy, but I soon came to realize that we're really combating that stigma across many different areas. And so I think that, again, we try to be really careful about our wording, about the opportunity presented by having these conversations, because that suffering can't continue. I interviewed Dr. James Seegers, who headed the National Institutes of Health Division in charge of women's health for many years, and now he leads a center at Johns Hopkins University. And I asked him why he became a gynecologist. And he said to him, the uterus is the most fascinating organ in the human body, male or female. And then to know him, you'd find this is funny. Hillary, I know you'll know. He's usually very like, he doesn't emote really. And he said, Soteria, can you imagine if men's testes grew 20 pounds their normal size and wouldn't shrink back down? He was like, we would have had a solution decades ago. And that's very blunt, but it's very accurate. And that's where we are right now. So having those without a uterus in this conversation is pivotal to move this forward. And I really think that us having these conversations, when I first started advocating, it was 2007. And people were like, you're talking about what? You know, but now all these wonderful, amazing advocates and individuals are openly talking about periods and menopause. And it's, you know, so we just need to just know that we're moving in the right direction, I feel, and do more of that to cause, you know, really meaningful change to take place.
Yeah, I think that also one of the things is that women's health is still something like considered to be something separate from health in general. And that makes it also more difficult. And I think that just if as a healthcare professional, you always ask people about their lifestyle, about smoking, about drinking, etc. And if you are treating a woman, and it doesn't matter if you're an orthopedic surgeon or if you're a cardiologist or if you're a gynecologist, then it should be like standard to ask about periods, about pregnancy, if a woman has been pregnant, how the pregnancy outcomes were, and also about menopausal transition, because it really has so many connections with other parts of her health. And it can be mental health, it can be like women who have epilepsy, have epileptic attacks, can be also menstrually related. So in that sense, I think that we really need a whole change of how we think about women's health.
Question from Hillary.
So first of all, terrific contributions from our speakers and the panel. Thank you all so much for enhancing the conversation further. So I've got one question to the panel, and I think it follows the last comment, and then I've got just a comment of optimism. So this issue of why aren't we asking about reproductive symptoms? And this is a question to anybody who has an influence, say, with regulators. Because if you have a clinical trial, you have a CRF, a case record form, where we ask about the heart, we ask about the chest, we ask about the waterworks, we ask about the bowels, we ask about neurological symptoms. But we do not ask routinely about reproductive tract symptoms, periods. You could give 4 questions and pregnancies. It would not make that piece of paper or that eCRF very much longer. But it is a very difficult conversation with industry to try and say, if you're doing a clinical trial, you know, if you have a sheet, whether it's on paper or electronically, you know, are you having periods? Yes, no. If you aren't, you know, so yes, 50% if it's a trial on a drug for the latest heart-related tablet that you might take in your 20s or 30s or 40s, you know, did the GLP receptor antagonist studies, for example, include in their CRFs about periods? We know they weren't asked in COVID, and so when the MHRA got its yellow cards about change in period experience, they had to convene an expert group because, again, a vaccine had been developed that was going to be given to all members of the population, but nobody asked the question. So it is, how do we get, because if the FDA asked for it, and the MHRA asked for it, and the EMA asked for it, we would then get those questions asked, and that would immediately raise awareness. So that was a question for the panel, if anyone can help us there. And the other one was just, Soteria, I like the way you say we should be positive about things and have optimism. So there is some movement in WHO. They knew they weren't going to meet the anemia target by 2025, so they've reset it at 2030. And they now have this additional pillar which asks about abnormal uterine bleeding. And of course, fibroids, although they may not be mentioned specifically, let's hope they are. It is one of the major causes of abnormal uterine bleeding. And they've just closed a call for experts or input, and I hope those with lived experience have responded to the call, because they're going to develop a guideline on menstrual health. So there is an opportunity, you know, for a big organization to hopefully help us in that positive direction that we're all anticipating. But I'd like to return to the regulator question, because we do need that as a question in clinical trials.
Yeah, I'm happy to go or start off with. I think that's a great question. And working originally in the first part of my career clinically and then moving into working with industry, I can definitely say that from my experience, the shortest answer of why industry won't do it is because they're scared. They're scared by what will the results, what will they find? How will it change the outcomes of what they find? Well, because what I'm pushing for is actually, let's not be scared about it. Let's look for the differences. GLP-1s is a great example, and actually say, when we're asking these 4, 5, 10 questions, whatever it be, then we can actually really start to stratify the results and understand what's going on. So it's not just that really crude thing, male, female, age stratification. It's actually looking at, are you actually still menstruating? What hormonal contraception are you taking? Are you perimenopausal? Are you postmenopausal? Are you taking GLP-1s, etc., along with the reproductive symptoms, as you said. But quite often what I'm hearing back from industry is, oh, how is that actually going to affect it? You know, is that going to change it? Is it going to lengthen my trial? Is it going to be a problem around recruitment? And more so, nobody else is doing this and I don't know what impact it will have on the results and where and how I want to market it and where and how I want to take it to regulators. So there is a concern there, and I think that needs to be driven and kind of recognised and talked about with the involvement of the regulators. On the other hand, it's great to see that WHO a couple of years ago is pushing to say that in clinical trials, as you well know, we should be looking at sex disaggregation. Let's separate it. Let me get a female results, let me get male results. But it does need to go further completely. We're at the beginnings, but I think industry, who will lead on clinical research at that very high, kind of mass level, we still see that they're very concerned about it.
Okay, so a comment there. I've asked members of, representatives from industry and from pharma many times why it is that only 1 to 2% of all research funding goes into women's health. And they used to say to me, because it's a niche market. To which, of course, my response was, which bit of 51% do you consider it to be niche? But let's move past that one, because they don't answer that to me now because they know what my response is going to be. But I do think we need to think, and to the lady who asked the question about politicization, I think it's crucial. In the same way that when I was, if you don't mind me saying, your age, I wanted to be recognized and promoted on the basis of the quality of the things that I did. I now realize that unless we prioritize women until they're 50% sitting at every table, we can't afford not to be, if you like, gender specific or gender biased about that. So I think we've got to get to an even playing field, and I would say as well that if you're trying to change something in a country at national level, then you have to get politicians to, you have to tell them a story. So if you give them a whole load of facts and figures and percentages, they won't remember that. But if you can give them a story which resonates, preferably if you're talking to a man, to a woman or a girl in his life that he cares about, then they will listen. And they will remember that story. They won't remember the percentages and everything else you said, but they will remember your story and they will keep repeating it. So I think that we do need to risk the politicization and the, if you like, the and the bandwagon, well, it is, the bandwagoning, if you like, because until we get onto an even keel, we have to do something about the fact that women have really had a very bad gender health gap. They've been seriously disadvantaged. And then when we've cracked the gender one, we've then got to look at the disadvantage between women and within women's groups. So for example, I challenged somebody at a female prison about 3 years ago, well, why don't you have a women's health hub? And I'm really proud about the fact that, having shouted about it so often to the Department for Work and Pensions and the Home Office, to people about this is shocking how women who are detained, the way they are not looked after, there is now a women's health hub in every single one of the 12 female prisons. Now, that's a tiny percentage. It's a tiny percentage of the prison population, but for those women who go into prison, it's a really turning point. And I love that comment you made about the percentages as well. So there's this wonderful story about sildenafil, which is now known as Viagra. It was originally came onto the market as a treatment for painful periods. And a group of male researchers decided that that wasn't an important enough problem for it to be investigated any further in women. So the data was dropped until it was found that it was a treatment for erectile dysfunction. And then within a year, you could buy it not just over, from the pharmacist, you could buy it over the counter. It was on the shelf. So my point rests.
And I think one more point on politicization. So what my experience in politics was that female bodies are actually already, in that sense, I'd say in a negative way, a priority for some of these politicians. I've seen it with my own eyes and heard it with my own ears, how female bodies are being misunderstood, but how it's also being weaponized for a political agenda. And in a way that women do not have a hold on their own bodily integrity. So it is extremely important nowadays that women are in politics, that we have the right ambassadors speaking for women's health and female bodies, as also a lot of misinformation, especially through social media, is being spread. So when it comes to the bodily integrity and having control over the information that you receive about your own health, I'd say that we do need more political debates about women's health and spend more money there. When it comes to the question on regulators, there's of course this layer above it, and that's where politicians and legislators should set the standard and also demand that guidelines and practical standards, and even when it comes to conducting clinical trials, that the right questions are being raised, but that also the quality of these trials are being safeguarded. And this is exactly what politicians and legislators can demand, but also in terms of funding and investment. Why are we still allowing it, right? Why that only 1% of the funding in general is going to women's health-related research? This is also what politics can demand. Put targets in policy, put targets in legislation, and if investors and companies in the industries don't comply with that, then that means that you're going to be excluded from cooperation or other kinds of benefits. So this is really where legislative frameworks can set that standard, and why we really need to bring it into the political space. And then there's one last thing I believe with framing, and I've seen that with fibroids. So there's this framing that we have when it comes to fibroids, as if, because it's not a cancer, right? It's not cancer, so in some way, people do not associate it with something very bad or extremely dangerous. But look, I did not study for it. But for example, our dear professors who are here, the people who studied for it, they tell us all the time, fibroids are not to be underestimated. Why is it that so many people are treating it as if, oh, you have it, okay, well, let's go along with it. But if we see in practice what the impact is on women, also in terms of participation in the workplace, fertility indeed. But it's not only with fibroids, it's with all the uterus-related conditions that we see that the impact is enormously. There are several impact assessments already out there. One of the most famous ones, indeed, World Economic Forum and McKinsey Health Institute. They show us the statistics. Even if you solve PMS, PMDD, if you solve indeed the issue of endometriosis or the menopause, the global economy can benefit from it so well. But we should not only present it as a business case that you should invest in. I think politicians and legislators really need to understand how we are all impacting by it, by the fact that we don't see as much as women in the workplace because they are affected by menstrual pain, their bad periods, endometriosis, adenomyosis. We need to understand what it does to women, our families in general. If women do not maximize their potential, if they cannot thrive, the whole society, and that's not something, moral only or a story that I'm telling, it's also what the statistics are showing, then the whole society is not using its full potential. And I think that's the frame, I think that's the story that needs to be way more and better understood by everyone, especially politicians and legislators that are involved.
Thank you very much. Thank you very much. So Just before we move into our next break before the in conversation, just had a last question for all of our panelists if we go down semi-quickly. But just to say, from what we've heard today and all these discussions that we've been having about fibroids, about women's health, what do you think should be the main priority for policy, either nationally in the UK or internationally by bodies like the WHO and UNICEF about fibroids?
Okay, I'll be brave. I want to, before I retire, I'm determined to get a question about menstrual health into every healthcare professional's repertoire. So if you go to the orthopedic surgeon, I want him to say, Leslie, it would be diplomatic to say, do you still have periods? And I can say, no, I'm happily menopausal and on my HRT. But if I say yes, all I want the orthopedic surgeon to say is, do they ever stop you getting on with your life? If the answer is yes, that's not normal and you need to go and get help. So I'm not expecting any of these other professionals to be an expert on it, but I am expecting them to ask, because as I said earlier, and I think I said it twice, there is nothing else that happens to a human being quite so commonly as having 12 periods a year for 40 years of your life. So we do really have to get it into that thing. How many times have you written down what you're allergic to or what operations you've had, including T's and A's when you were only 2 years old or something? But we answer that routinely. And if I saw you and I didn't ask you those things, you would think I'm very sloppy. But I haven't asked you about those two things. Do you still have periods, or do you have periods? And do they stop you getting on with your life? And that would cover all of it, wouldn't it?
Yeah, I think so. That's really indeed to have a core question set for like all healthcare professionals, but for example, for operations, if you have an operation and you have heavy bleeding, can you imagine what happens if you're operated during your menstrual period? So also there with diagnostic procedures, such as also blood withdrawals, they're always asking, are you fasting? But nobody asks you, like, are you pregnant, for example? They don't even know that. Are you in menopause, and on which day of the menstrual period in your cycle are you? Because that can really differentiate. So we don't know very much about the difference, the differentiation, the variation in blood levels across the menstrual cycle. I work in lipids, and during the menstrual cycle, you have already different lipid levels. So I think that's really integrating women's health, including fibroids. Then you can just really see the bigger picture, and then you can maybe also discover how fibroids affect like a lot more of women's life than we even maybe notice. And of course, people with lived experience know. And maybe they will recognize like, hey, also like, migraines are associated with fibroids, and not a lot of people know that. And maybe we can even better connect the dots and improve also the life of women with fibroids.
I can carry on that point. I think these are great suggestions, and I just think I would really just repeat the need to actually really investigate. Is it impacting you? I think, speaking as a doctor, I can definitely say that in medical school and throughout all my training, the focus is getting the information. Do you have this? Do you not have this? Is this happening? What's going on? But actually, as I've got older and experienced more different things, it's actually realizing how does it impact that person in front of you. Everybody can experience the same thing in a completely different way, and the impact that has on you is the key thing. You may bleed the same amount as somebody else, but what's that impact it has on you? And I think that's really the screening question to ask, obviously along with, are you still having periods, but what's the impact it's having on you? And I think really focusing on that will help us move, essentially in answer to your question of what would I like to see, is to stop being reactive to everything all the time at the very worst case scenario with the very most complex case, but actually go, you know what, this girl, this woman, she got picked up at 19, or even if she got picked up at 40, that was the beginning of when it impacted her. And we were on it straight away, and we diagnosed it, and we treated it. We still do all of that, but we just take so long to get there when everything is at the very worst part of the situation. And obviously, economically, it makes no sense. And more so, it makes no sense to the poor woman who's suffering.
Great comments. I'll just add that I really believe in my heart that the funding for uterine fibroids globally needs to match the size of the community impacted. And we're talking billions. So billions of research funding, it's there, it's doable. It's just a decision, in my opinion. We talked earlier about, I think you mentioned when someone's personally impacted. I always invite members of Congress to go home and ask their family members who's had fibroids. And when we have a conversation, you can see the shift in their thinking on it because they find out that their mother had a hysterectomy for fibroids or their sister had birthing complications. In the US, the congressionally directed military research program funds about 40 health concerns. Endometriosis is on that list. And endometriosis is on that list because the late Senator Orrin Hatch, who was head of the Senate Finance Committee, had a granddaughter who was suffering with multiple surgeries for endometriosis. It's a decision. It's your awareness and a decision if you're in a position of power to allocate funding. And those are the conversations that I look forward to continuing to have.
Just one sentence to add quickly.
2 seconds.
Yeah. More research on the holistic approach of fibroids and the holistic causes, because I would like to know way more about the relationship with endocrine disruptors in general versus uterus related conditions, but also food. How is our food patterns and the products that we use on a daily basis impacting fibroids, but also other uterus-related conditions. That's extremely important that we're going to put money there. We have seen the first researchers already showing up, but it needs to be scaled up, and we need to have more insight on that.
Thank you so much, Samira. And I think actually that can be picked up a little bit later by Soteria. I'll just pass to Jasmine now.
Yes, well, first, can we get a round of applause for our panelists here? So we'll now be moving into a break that we'll have from 5:10 to 5:40. This break is all about the coffee, tea, and biscuits, but it is also about reflection. So we have some just paper out in the break room, and we would love it if you would please jot down your thoughts, the questions that you didn't get to ask, the points that you didn't get to make, the things that were discussed here that you found extremely important, because we want to hear all those things. We'll be writing a report, and we want your voices to be part of that, just like the voices that have been on this stage. So we'd really, really appreciate some reflection as you enjoy your coffee, tea, and biscuits in the room where we were before. See you back here at 5:40.
I'm just going to take this out. Okay. Have you got the other little bits?
I just wanted to ask you because our state secretary, Judith Thielen, she mentioned that she was going to meet you, and she asked me if I could send her a T-shirt to give to you.
Oh,
but
right.
I wondered if you ever
marvelous! Yes, but
received the T-shirt.
No.
Oh no!
No, what was it? What was it?
It was a T-shirt. It was our T-shirt from our women's.
Have you got the little piece on the end? Sorry.
Oh, no, I'm not listening.
Crucial.
Oh, was it the adapter bit?
Yeah.
Don't know where that's gone. Where is,
sorry, go on. Oh, no, I haven't done that. I was surprised.
Oh, really? And because we had those T-shirts back t-shirt saying, girls just want to have fun and then dig for women's health research and innovation. Well, then I can send you a t-shirt anyway if I have your address, because they were really highly in demand, because when we opened our center, we made those t-shirts, and everybody came to me and said, oh, I want to have this t-shirt with girls just want to have fun and do research.
Oh, you're wonderful. It's very, very soothing.
That, I have never seen one of those. It's so compact. Yes.
Yes, please. No.
Well, and in the Netherlands, all the t-shirts are really big, so I always have to ask like the smallest. Yes, exactly. It's good that I now meet you, because then I know which size t-shirt you need. Otherwise, you don't need to wear it. I would have like very small. They put it through and they couldn't chuck it out. Why didn't they go through? Because I'm going to come
Hello, everyone. If you could take your seats, please. So we are very happy to be, oh, is the sound okay? We're very happy to be back just for our final session. This will be the In Conversation with Soteria Venable and Lord Simon Woolley. And just to kick this off, I would like to introduce Candice Bryan. We can welcome her to the stage. We're very lucky to have Candice with us here today. She's filling in for Dr. Francesca Moore, who was unable to make it. But Candice is an accomplished health equity strategist and program architect. She created the UK's first fibroids education program for Black women living in the UK, and she works as a public health strategist for the London Borough Council. And she also sits on a community advisory board for Black Health Legacy. So we were very lucky to have her with us and leading this conversation. And then I'd also like to welcome Soteria Venable, founder and CEO of the Fibroid Foundation, who we all know very well now, and also Lord Simon Woolley.
Good evening, ladies and gentlemen. We've reached the final part of today's wonderful conference. Thank you for that kind introduction, and it's a pleasure to be here with you all today. Wow. So thank you so much for all that you shared today and your magnificent opening this morning. I want to start with Soteria. Tell us about your journey. How did you start? And what has been exciting and promising? And also what has been the greatest barrier to getting fibroids recognized as a legitimate public health and policy issue rather than a private women's problem?
Sure, so thank you again, and I want to reiterate how wonderful today has been, and also that we should see today as accomplishing a major, major, major stepping stone for taking this conversation to the global stage. So again, Priscilla and team, just incredible. So I decided to launch the Fibroid Foundation because I was a frustrated patient. I had had 3 fibroid surgeries. I lived in Chicago at the time, and I thought, I'm in a major metropolitan city, I'm having so much trouble finding a provider. What are other women experiencing? And then I kind of delved into the statistics and was just kind of blown away, because at that time, like many other women, I felt very isolated. My life revolved around, you know, fibroids, social commitments, canceled. And I thought, if this many people are having this issue, why is everyone not screaming from the rooftops? So I just started having conversations and blogging my experience month to month. And it started to kind of gain traction. My mentor, Dr. Elizabeth Stewart, is at the Mayo Clinic, and she has really been a gateway for bringing us into the research conversation. And I also remind everyone, I think there was a question about advocacy earlier. If you just do whatever you're comfortable with and bring that to the advocacy space, whether it's volunteering or anything, can be helpful. And today we reach over 180 countries. We have several chapters, and we've been able to accomplish some major things that have made me just have warmed my heart. Like, for instance, we talked about research. We were able to have one of the research studies that we designed, that patient input added to medical board exams in the United States. That's one of the ways that the patient lived experience can directly translate into policy and medical treatment and care. We've been able to make inroads in terms of consulting on product development, and reaching our community, being a resource, helping women and menstruators to avoid hysterectomy. One of the issues is that we'll get a communication from a patient who says, I have one fibroid, and I was told to have a hysterectomy. And then on the opposite spectrum of that, we have Dr. Soni Singh, who's on our medical advisory board. He's at the University of Ottawa, and he removed over 50 fibroids from a woman, kept her uterus intact, 3D mapped her uterus before he did the surgery. And that type of disparity in the expertise is something that we really are working hard to, just be a gateway to help our community members find the right practitioner near them. And convenings like this are so important because, it's enough of a challenge to find those resources in communities you're familiar with, but to also be sensitive to cultural barriers in other countries and just the way of doing things and how the medical systems operate. That's why these conversations are so incredibly important. And I think the barriers definitely have been funding, like really, really recognizing this for the major, not only during the reproductive years, but we mentioned ferritin. Ferritin can be high if you've had decades like I have had of anemia. There can be cardiovascular implications. We don't have enough data on how fibroids patients should be treated through hormone therapy because our systems are so sensitive to hormones that hormone therapy may be very beneficial and needed, but it can't be dosed at the same amount as someone else. So that takes you on the entire lifespan continuum. And so those are some of the things that still cause great concern for me.
Satira, firstly, thank you for all the work that you've been doing and your journey to this point, helping globally, starting off as a patient advocate, then moving into awareness, moving into research, impacting policy, legislative change, I think is a phenomenal work that you've done. And it sounds to me like you've only just begun. So I wanted to ask you, Lord Simon Woolley, you occupy spaces where men often shape decisions. From what you've learned, how does listening to women's experience, such as Satira and some of the women here today, with fibroids change how men should engage as allies? And as a male ally, what do you wish you would have known about uterine fibroids? And how can we get men to understand that this is a family issue and not just a public health crisis?
Thank you, Candice. And it's a great question. And this has been a great gathering, by the way. I have a number of observations. It's rare to have a gathering like this and people speak to you for about 4 hours. And nobody's drifting off because the level of the panelists have been so engaging that people have just wanted to listen and wanted to learn. Is the first observation. For me, sitting at the back and listening to the expertise, the talent, the desire to move the dial, I must say, is everything I want from my college. Everything. And to know that a group of women have said, we want to do it. They didn't come and ask to do it. They said, Simon, we're doing it. And I said, I'm here to help. And it is about that allyship. I was speaking to a nurse that's here, Clementine, and she was saying to me, Simon, this is a wonderful, wonderful conference, but isn't there a question about, and I'm paraphrasing, the medical profession when it comes to women's healthcare? And too often, male practitioners think this is nothing to do with me, or less to do with me. And I just wonder, that there was a point in which somebody said, you know, if this had to do with male testicles growing triply, there'd be a cure by now. and it would be dealt with. So there is a disparity, and whilst I'm pleased that this is a mixed audience, I wish more men were here. I do, and I think Dane, where is she? She's at the back. She's still here. She's still here. I think there's a great moment that I think you all should learn. As you have to be advocates, you have to be political, and I think one great piece of advice that she gave to you was to tell stories, to think about who you're speaking to, how the story will land, and make it personal, or personal to them. One of the challenges that the team here will have is, today you've had a great day, really great day, and I'm sure tomorrow you'll be thinking, oh gosh, I'm exhausted. No, that's when the work starts. Okay? The follow-up, the pulling this all together, and the actions that come from it. I'm just thrilled to be an ally and to be a small part of this.
Thank you so much. I'm going to move back to Satira, and just to touch on that point. One of the women in my own program described what the absence looks like in practice, and she said, lifestyle practices that would have helped me to move forward after my surgery weren't explained to me. And often I hear from women who were enrolled in the program and who are still part of my support group, they keep saying, no one told me, but no one told me, especially after they've had surgery. So in terms of, your work and how you've really, pushed forward legislative change, how should policymakers understand fibroids as part of the broader structural inequalities, particularly affecting Black women, because we know that they are disproportionately impacted? And what role should patient organizations, community organizations such as yours, play in influencing, researching, funding priorities and regulatory decisions?
That's a loaded question. There are so many facets to that. I really think that, earlier we were having a conversation about the patient experience. I try because a lot of us, when we work in certain arenas, we get used to having conversations and we forget that sometimes there are people who have no idea what we're talking about. And I worked in the construction arena, and then I worked in the medical arena, and the same thing holds true. It's like all the doctors think that, they have conversations and think everyone understands, and same thing with construction. And so I try to explain, like, if we say myomectomy, what does that mean? That I was cut open, my uterus was lifted out of my body, the fibroids were cut out, the uterus was sewn back together, and then the uterus was reinserted. How many people knew that? Okay, and that to you paints a picture of what someone has endured multiple times in some instances to conceive or to avoid pain. And again, storytelling is so really important to be able to relate. And even if you have to repeat things as an advocate several times, there's someone that has not heard that information. I think to your point of being heard, it's a two-way street. The ideal way to move forward is we call it shared decision making, but also shared advocacy between providers and patients. Because I realized through Magdi Malad, he did that surgery that I just described to you. He's on Northwestern's team, and he's also on our medical advisory board. And when he did my myomectomy, I realized that I was educating him as much as he was educating me. I was lying in the pre-surgical bay, and I heard a woman beside me saying that she had had some symptoms that I had had, and it was related to the medications for the surgery prep that had taken me on this spiral of high blood pressure and, you know, all these different things, and no one told me, you know? And so the patient voice is just really, really pivotal in helping other patients to fill in those gaps where the provider may not have time or may not know because they haven't been a patient. Like we have provider connections and personal connections that I have with providers where I've told them, you need to go have surgery. Like, and they haven't even considered for themselves that it's time to stop this suffering. And sometimes you just need someone who's walked that journey to tell you, to reassure you that it's okay, and that it's interesting to me too that in the US, there's a stigma of treatment based on the history of slavery in the United States. It's interesting for me to hear that there's also that hesitation and fear here in the UK. I would love to delve into that some more at another time, but I did make a mental note of that. But, so I think the conversations are key for really overcoming those fears. And then I think, you said barriers was the last one, to just, I think people really need to understand, sadly, you would hope it would be empathy, but they need to understand how this affects them. And there are many components, as I mentioned before. Like when we were on Capitol Hill, there was the military. In the US, a lot of research begins in the military arena and then expands into the community at large. So we've been working to get fibroids covered in the military arena. And so any congressional members who have a focus on military readiness will sometimes lend an ear if they see that connection. So just kind of meeting people where they are, helping them to understand, inviting them to ask their family members who's been impacted. And I think the challenges there have been to get that level, find that conversation or that piece of data that's going to spark a change in behavior from a decision maker is what I'm constantly trying to work toward. And I don't want to provide a problem without providing a solution, because the lawmakers said to us, oh, well, who's impacted in my community? This is going back years. And so we're getting ready to launch a database this year that's going to list by zip code every woman who's been diagnosed with fibroids over the past 5 years. And it's going to be publicly available, so that when we walk into an office, no one can say, well, who in my community is impacted, because they can just look it up right away. So we're just, you know, I'm always trying to think about how can we push the envelope? How can we make sure that this is being considered as a major, major, major community-wide health concern?
Thank you so much. And I think what I'm hearing there is the scale of the problem once we've got the data, and certainly for us in public health, that is where we start. We start with evidence-based data, and driven from the community, I think married together can be quite powerful. Thank you. Lord Willie, your team has worked tirelessly to bring this initiative to the point where we are at today. Can you tell us what has personally driven you to support this work, and why this moment matters to you?
Well, as I said, I want this to be part of the Homertons. This is what we do. I have an open door policy. I take the Lord off the title. It's Simon Woolley, and I love people to come through the door, and students or researchers like Priscilla come in their door with an idea, and they say, I've got an idea, and I'll say, I'm not listening unless it's a big one. and not listening unless you're prepared to roll up your sleeves and be an activist. And do. I mean, I'm only here for a few years, but I want my time to be people believing, showing they can make a difference. And of course, you know, whether it's a white woman or a black woman or East Asian woman, they all get the same treatment at my door. They all get the same treatment. But when I get a woman like Priscilla who is shy instinctively, and I can in real time see her grow in confidence, and then go to the House of Commons and tell politicians to wag her finger, and then fly to Washington, D.C. and meet up with this super sister. I mean, this is a super sister right here. Right here. And Samira from Holland. Samira and I go back 15 years when we was at Operation Black Vote. We had these programs to nurture talent to become leaders. And then we opened it up in Europe and the USA. And we'd meet in Brussels for a week. And we would nurture them and train them. This young woman came to us and said, Simon, I'm going to change the world. And I said, you're at the right place. And then some 8 years later, she said, Simon, I'm literally changing the world because I'm going to be the first woman of color in Holland to become a member of the European Parliament. Does my job get any better than that? The critical part to it, Samira reminds me, she says, do you remember, Simon, what you taught us back in Brussels, way back then? I said, of course I do. It was my job to teach them ethics, values. Of course I want them to be brilliant, but being brilliant without values, being brilliant without ethics, you become self-serving. And I couldn't nurture people that would go into the European Parliament self-serving. And she's been a great credit. And I feel blessed that I'm in this space with the Homerton team. Some of my fellows are here. John, I'm looking at you, and Mel, I'm looking at you. And we're just on a great journey. Great journey.
That's beautiful. Thank you. Thank you. Yes, please, a round of applause. Thank you. So I'm going to stick with you, Simon. And you are, you know, the founder of Operation Black Vote. You spent decades showing that political representation is the lever for systemic change. My question is, how could health inequalities be leveraged to inspire government and the House of Lords to treat uterine fibroids as a public health crisis and not just a niche women's health issue that we've heard about earlier? And as you said, you know, there's an open door for Homerton College. What role does Homerton College play in helping us to deliver that long-term vision?
Well, I think a better person to ask is Satira, really, because, I mean, you know, my job right now is to be an ally, and let the experts speak, and the experts speak. The best role I can do is to support, and to let people like Priscilla and her team know that politics is a numbers game. Don't ask, demand. And finally, that everything that you do is you have the moral majority. Everything. You're on the side of the angels. I'm here to tell you it's not enough. It's not enough. Just because it's the right argument doesn't mean it's going to land. So, what Satira will tell you is, you've got to have all of that, and you've got to be smart. Wrapping it up. How do you get it to land? How do you get that person to nod with you, sign the check, and you can move the dial? But let me ask the expert, because you've moved the dial on Capitol Hill.
No pressure. You have made it possible for us to be here today, and we are so grateful and looking for others to replicate your openness to inviting us to share our stories everywhere. And the power of the patient voice, the power, of anything, this walk has taught me that if you follow your heart and you move in the direction of your interests, the serendipitous moments that have happened, and Nikki can attest to this from my team, and I want to acknowledge Nicole McCombs, our events director. She's amazing. She made the trip with me. The serendipitous occurrences that take place are just mind-blowing. Like, for instance, we are a part of a National Institutes of Health study on fibroids, and it's active. We're getting ready to start year 3 of 5. And the Fibroid Foundation was the first organization to find out that it had been funded. And in the United States, most often, I don't know if it's the same in the UK, a nonprofit organization will partner with every medical team that's applying for the grant. And I decided that I didn't want to do that. We had worked on the Compare UF study, which was a $20 million 5-year study looking at treatment options, and with Mayo Clinic. And so I called Dr. Stewart and asked her to work with me to put together a team, and we only went in with that one team. And some people really got pretty flustered, their feathers ruffled over that. But we won. We got one of the best scores ever for an NIH study submittal. It was 800 pages, something that we could have never done as an organization by ourselves, but by taking a step to make sure that the team that we selected was stellar, we were able to make that happen. And I've seen over and over again with some of our pharma partners how they'll start kind of gingerly with a relationship in one department, and then by the time we grow our relationship over years, we're working with 4 business units. And then that gives you the capability to really build I love relationship building. I come from a business development background. And I really love nurturing those relationships. And I decided, this is an aside, I worked in construction management in Chicago. Construction management can be a really brutal environment to be in, especially a female, because there are very few females. And I decided after that experience that we weren't really going to work with people who weren't good people to work with. So it's not about what you're looking to offer us in terms of funding. It's, do you have the moral capacity and focus to be a good partner? And so I think those dynamics are not only liberating, but they create an environment where we can get a lot done.
Thank you. Thank you. Thank you so much. We're now going to take some questions from our audience. It's been a long day, and I'm sure after all the reflections and connections that you've been doing, you have some questions for Lord Simon or Satira. We have one there. I have one. I have another one.
Thank you very much for those talks and speeches. Are really inspiring. I just wanted to ask, how do you keep yourself safe, and how do you keep yourself driving? Because when you are making change and changing at scale, you're sticking your head very high above the parapet, and you're going to get shot down. So how do you continue to drive? A little bit about psychological safety, I suppose, but what works for you guys?
done it my whole life, so I don't really think about it. Yeah, I don't really think about it. I probably need to strike more of a balance in terms of self-care, which I've started to implement over the past few years out of necessity. I find that our community, our team is really reassuring. I also had a ton of family support through this whole journey. Shout out to my mom who just passed away. It'll be 2 weeks tomorrow. And when you have that type of support, it moves mountains, you know, it really does. So physical self-care, mental self-care, the community around you, and to celebrate the wins. You know, we don't do enough of that, and I'm trying, Nikki and I not trying to make sure that we celebrate the wins. That is really important. When you do something like what you just presented, you know, celebrate it. Take the team out, you know, do all the things to acknowledge, because we accomplish one thing, and sometimes it's quietly because we're at our desk and we don't realize what we've done, and we just kind of go on to the next thing. And another thing that's really important is that when I meet patients and they're like, oh my goodness, you know, and they'll tell me how something they read or saw or heard impacted them, and I would have no idea. And that kind of refuels me a lot, I think, more than anything else.
I have an invisible flap jacket. I do. It's needed. A hard hat. If you want to make a difference in the world, your starting point must be, it's thankless. If you start out with that, you won't be disappointed. But you wake up every day thinking, I'm blessed because I'm trying to make a difference. And that fuels you. If you set out that you do this because it's the right thing to do, it's not for trinkets, it's definitely not for financial gain, you will be surprised when somebody says, because of you, you might not remember me, but now I'm a member of the European Parliament. That I was inspired by you. And it's those moments, as you said, Satira, that you need to accept and to run with. I must say to the team here, not right now because there's still a bit of work to do, but a bit later, embrace this success because it's a huge success. You don't bask in it, but take it, learn from it. They've already been saying to me in the corridor, so Simon, what's next? You know, that's also part of the success because you're inspired to do the next big thing. One last thing, you do have to take care of yourself. My go-to is to get up at 5:30 in the morning and go for a swim. And actually, when the going gets tough, I swim harder because I have to say to myself, you're going to need to be strong. Swim another few lengths. And you have to find your own thing that gives you the resilience, the fortitude to get back on the horse and do your thing.
Thank you, thank you. Do we have any other questions?
I've got one shout out, actually two shout outs that I nearly forgot. Can we hear from the Norwich Massive here today? Where's the Norwich contingent? Where are you? I know there's some from Birmingham. Where's the sister from Birmingham? Birmingham, where are you? Where are you? I know someone came all the way from China. No, but she said she didn't come all the way from China, but she just joked that she did. it's great. It's great to see so many people from different places descending on Homerton to make it shine.
Thank you. Before I close and hand over to the team, I've got one question. We're in a room full of clinicians, policymakers, commissioners, patient advocates. What if every person left this room and did one thing, just one thing differently? Whether they work in public health, policy, clinical practice, or education. And it's to both of you. What is the one thing that you would ask them to do?
I would say center in on what touched you the most today and take an action consistently on that one thing. Like make a note on your calendar every week to just, did I do something to follow up on this or to support this thought that I had today, and do that, or reach out to the person that you wanted to connect with. That's the thing I would recommend.
I would say that when you're looking for the leader who's going to make the difference, look no further than the man or woman in the mirror.
That's powerful. That was powerful. No pressure, no pressure. I want to hand over to, I think, yes, please. Jasmine, sorry, thank you.
Thank you very much to everyone. Oh, now the mic's too loud. Oh, Lord. You guys, if you'd like to take a seat, please feel free. And another round of applause, please. Now, just for a closing here today, I know I'm the last thing standing between you and a drinks reception, but I also think that the incredible nature of today deserves a moment of reflection among all of us. And I think a phrase that really sums up what we've created here today is that of a crucible moment. The tides have been changing, people have been speaking up, but what we have today is a pivotal point where we're able to take these action points that we've created and bring them forth. And it's really the people who are here in this room today and those who are online and those who have been contributing behind the scenes that have made that happen. So I'd like to take a moment to do a round of applause for everyone who's here today, and thank you all for being here. We began today thinking about patient awareness and empowerment and really that courageous vulnerability that is so poignant in bringing these journeys to life and bringing these voices to life and giving people the opportunity to share their experiences. We then moved into thinking about transforming the culture of education and clinical practice with some really hard-hitting questions and really looking for the accountability in terms of what people are being taught, what is being discussed, what questions are being asked in the examination room. And it's really the idea of the voices of patients as teachers that we've all come together around, and thinking about those silos that we've spoken about and how those could be brought together around those patient voices. And then moving into that pathway to legislative change and how fibroids can be incorporated in national and international initiatives, and how menstruation can be a part of every conversation that happens in the examination room. It's happening to all of us here with a uterus, and it's something that needs to be acknowledged. So today we've all called Homerton College, Cambridge, our home. Many of us here also call Cambridge our home, but I think many of us also call other places our homelands. And what I ask of you today is that we let today be the catalyst for a diaspora of the knowledge and the inspiration, and most importantly, the action that comes from the conversations that we've had. So please, as you go and leave today, take so much with you and bring that forth, because there are women many places, not just here, not just in the places that we regularly interact with, that need our help and need our support. And that's what we can do together. And today has been a true indicator of that. I would also like to extend some extremely heartfelt thank yous. Firstly, to Hillary Critchley, who has been with us every step of the way here in mentoring us and guiding us. So round of applause for her, please. I and the rest of the Fibroids-Free team would also like to thank our home department of Obstetrics and Gynaecology for affording us the time and the opportunities and the support to do this. So thank you very much, Gordon and Steve and everyone. I would also like to thank CSAP and Hologic for funding today and helping make this possible, along with Homerton College as well. And I would also like to thank all of our speakers and panelists and our international collaborators for making this the really pivotal moment that it has been. Just a few more, don't worry. I'd also like to thank the Homerton College team. As you can see, today has been a force of nature in terms of the coordination and all of the things involved. So really like to highlight Lester Holloway, Bailey Luce, Lily Bell Burden Ting, Emily Hutchinson, the internal events team, the IT team, and of course, Lord Simon Woolley for helping bring this together. So a big round of applause for them. And lastly, before we wrap up, I also want to say a sincere and heartfelt thank you to a group of women who allowed me to show up in September 2024 before they were about to run an event in November and say, yeah, sure, you can help us out with this. And this is the Fibroids-Free team from our department. You have been such an incredible cornerstone of my Cambridge experience and to the movement that we've created here. So I'd like to invite you all up to stand here with me because this would not be possible without all of the work that you've done. Oh, 1 second. Well, hang on, Lester. We're almost there. Don't worry. I'm going to say it. I've been instructed. Yes. So anyways, massive thank you to everyone. And one last round of applause also for all of our attendees who have really made today what it is. You filled those seats, and we so appreciate it. So now I am excited to release you to the drinks reception. However, if you were a speaker today, you may not leave. We will be getting a group photo all together. Everybody else is happily released to the Fellows Dining Hall, and if you follow students, there will be people to guide you across the lawn to the drinks reception, and we will all congregate there. Thank you very much, everyone.
That was great. That was great, thank you. Yeah, very exquisite.
To get the right slides up.
I think it might be over there.
Do you want me to put it on silence?
It's on silent. I'll deal with it later. I've got like the beep beep thing for my watch.
Okay,